all of you, I should say, go have a look after this. Okay. All right. You should be seeing my screen, which is today's presentation. And hopefully you all got the email I sent about an hour ago with the slides, the PDF slides. And hopefully there weren't any animation errors on any of the slides this time. Okay, so today we're going to continue talking about a little bit about personality, and then we're going to talk about disorders after that. This is the second part to the first part that we did last time. Before that, just a little reminder that we have office hours still, Wednesdays at 5 p.m. Pacific. They've been rather lonely, so if you want to join me, that would be great. And the last one that we have is on the 15th. So last chance to meet and do some of those. Now, this is the stuff that we started doing last time. So we're just going to finish up personality and psychological disorders. And the last thing that we had with personality that we had to do was just one perspective, and it was the biological perspective. I cut it out because to be sensitive for time, but also because it actually blends in kind of nicely when we're talking about disorders. So let's get started talking about the biological perspectives when it comes to personality. So you may or may not remember the name I can't even say this, Eysenck. Eysenck was a person that we spoke about when we were talking about trait perspective. And we brought up the acronym PEN for Eysenck. Does anybody remember what PEN stands for? Come on. This is a good one to know, because this one you will definitely have to keep handy. Yeah, okay. Okay. Alrighty. Perfect. I got in a private message. Yep, the same thing that Jonathan just sent. Exactly. So definitely don't forget that one. Yeah, if somebody could send the slides in the chat, that'd be so dope. So he was talking about trait perspective, but one of the things we didn't talk about when we were mentioning it for trait perspective is that there's actually some science behind it. Remember that a lot of these theories that we're discussing sometimes come with science backing it, and sometimes just come with a lot of observational evidence. Excuse me, I guess that is also science. What I'm trying to say is that there is biological foundation that we can link to, in this case, neurology. So when it comes to Eysenck, there is something called the reticular activating system, or it can also be called reticular formation. So have those two terms handy. It's located somewhere in the brainstem, and the image shows it as the whole purple sliver in the middle of the diagram. And the idea behind how this activating system works turns out to validate a lot of what Eysenck was saying. And it's really interesting because we were talking about in the case of extroversion, the E in PEN, we found out through research that extroverts and introverts have different levels of activation within the reticular formation. So in the case of extroverts, they have a higher baseline arousal, meaning that their level in order to get excited is much higher than that of introverts. So think about it in terms of like, if the baseline level is higher and the baseline is the same thing as your optimum level, that means that extroverts have to work extra hard to reach that optimum level, whereas introverts don't have to work that hard. So when it comes to, in the PEN acronym, in particular, the thing that I'd like for you to remember is that for the extroversion, there is good validation in the reticular formation, specifically the way that it activates differently for people who are found to be extroverts and introverts. So think about it in terms of like, remember we were talking about the trait theories. There were so many different surveys and questionnaires, kind of like the I'm blanking on the name, the four acronym, Myers-Briggs. So let's say somebody completes it and they are on a scale, on the extroversion scale, they hit high or low. If it's low, they're introverts. And if they go into their brain, they might find that the baseline of arousal is much lower than that. So hopefully that makes sense of how there's a biological tie-in with trait theory. The other thing to keep in mind from the biological perspective when it comes to personality is that one of the ways that it's really well studied is in identical twin studies. I say identical specifically because of fraternal. So hopefully that already rings a bell about the genetic makeup, that in identical twins, what you have is one cell that's been fertilized, and it's that same one that divides in a bizarre way that creates the growth of two individuals, versus fraternal, which is where two different egg cells are the ones that are fertilized, making them with the exact similarity as they would if they were siblings born at different time periods. So when it comes to identical twin studies, the thing that it's really good about is about determining what is environmental versus what is genetic, right? The nature versus nurture analogy. And the reason they're so good is because the identical twins, since they have the same genetic information, you can eliminate that variable, and all you're looking at is at the environmental influences. Particularly, these studies try to look at cases where twins are identical twins that are reared separately, meaning that they grow apart in different environments. And so then that way you can say like, okay, these environments were different in these ways. Are they still similar? And if they are still similar, then is it due to genetics and not the environment? There's two traits that are shown to have really good genetic components, or I shouldn't say good, I should call it strong genetic components, meaning that there is lots of evidence that that genetics are a driver for it. One is the social potency trait, which I've described right there as how a person assumes leadership roles and how they assert themselves in social situations. And the other one is traditionalism. So whether they tend to follow authority. There are traits that through identical twin studies, we found that have weak genetic components, meaning that they don't seem to be related in genetics. And one of them is the achievement trait, and the other one is closeness trait. They are basically what they sound like. The traits of wanting to achieve, being a high achiever, and the trait of being close to people. The particularly the weak genetic components make sense to me. It seems in my mind anyways, I would think of it as being the case that a lot of what personality traits of achievement and closeness are very tied in with environment. But then again, lots of things about the MCAT that you think make sense to you might actually not be the accurate information. So you can kind of put this on a minor flashcard and memorize it if you have time, only minor. The other thing I want to mention is that genetics also show up when it comes to particular genes. So instead of just comparing, on a broader scale of traits, we can look at the dopamine 4 receptors. And research has found that certain types of mutations on the dopamine 4 receptors will likely lead to have the individual being more of a thrill seeker. This is, however, modulated by the environment. What do I mean by modulated? I mean that Um, you can be a thrill seeker all you want if you have a particular mutation for the dopamine 4 receptor, but if you don't have anything that in your environment that is thrilling, then you really won't become a person with a thrill-seeking personality. If that makes sense. So genetics can only go so far. Your environment also has to provide the things that would make it really be expressed. The last thing I want to talk about in terms of biological perspective, I think it's kind of fun. It's evolutionary. I always like it when we tie it into evolutionary stuff of like why in the hell did we develop the way we did? And so the idea behind evolutionary for personality, as it is for any type of application of evolutionary perspective, is to figure out what is the basis, the biological basis that made personality the product of natural selection. So in particular, we're going to look at this in terms of traits. So we're back to trait theory and say like, well, why did if these traits that we think are part of essential part of personality, why were they functional in natural selection? Why did they stay? Whereas somehow got weeded out. So there's a really interesting perspective when it comes to the differences of gender. So, sex. And one of is that male and female mating strategies will produce different personality traits because of the fact that there is a cost difference in passing on the genetic information. This is something you may have to remember for the evolutionary side of biology section. But basically, I got a private message saying that it's more costly for women than men. It's exactly right. So for women, the cost of passing on genetic information is very, very high. Human females don't have 5,000 little babies and abandon them in like a little creek and then they walk away and then they die 2 days later. That's not how pregnancy works in humans. It's a very laborious process. It takes lots of energy, and therefore your mating strategy has to be one that is tries to get the right person, the right male, because it's so expensive that you can't just get anybody, right? You're not a spider. Likewise, with males, the cost of passing on genetic information is much, much lower, primarily because human males don't get pregnant. And so, therefore, personality traits would look different when it comes to reproductive fitness. So if you can think of just like pretty easy scenarios, you can think of, I don't have any specific one, but, in my mind, it's like male personality traits of reproductive fitness would be something of dominant, trying to find as many mating partners as possible, and kind of like lower levels of attachment. Whereas female personality traits of reproductive fitness would be something about being highly selective and closeness, because you want to have support system for pregnancy, and perhaps I'm guessing like skepticism, of like all males, so that you can just have a good selection process. So I hope that makes sense. And I really like these for some reason. I don't know why. But the other one I like is also the I got a private message. Think about the birdies and courting rituals. Exactly. The other one I like is the one that's proposed by David Buss. You don't have to remember the name. Remember how we talked about the perspectives last time and all those names? You have to unfortunately remember those names. Not this one. But the idea that Buss said was that the big 5 traits actually can be traced back to being favored by natural selection. So the fact that we today have those big five traits that encompass lots of little traits is a result of us having evolved with those, whereas something else got lost in the process. So the idea that extroversion is actually the ability to bond with each others is really good, because if you are a, oh God, I forget my evolutionary, but let's say you're Proto-Magnum. I forget what they are. But the idea is that whatever our ancestor was the first one to kind of bond together into groups to increase your chances of survival. Well, that's extrovert. Um, the willingness to cooperate and collaborate is agreeableness, another way of kind of sharing resources and helping each other, because that also increases your chances of getting passed on through natural selection. Conscientiousness, reliability, and ethical, and then openness to extroversion. And so being a problem solver, that's a really great trait, because that way you can create the wheel and not drag things along. And the ability to handle stress and low neuroticism can be great, especially when, I don't know, you're trying to figure out how to get a saber-toothed tiger out of your little village. I'm just making shit up now. But the idea is you kind of get how this idea was that these big five traits actually could be argued that are a result of natural selection. When we talked about big fives, I gave you an acronym to remember. Do you remember what it is? Cool. Awesome. Perfect. I just got several private messages, all which were right. So I always encourage you to um, not send direct messages if possible. That way everybody can see it all. And most of you are always right. Okay, so any questions about personality? Specifically, we just talked about the biological stuff. No? Yeah, it's pretty straightforward. All right, now we're going to talk about the second part, which is the psychological and nervous system disorders. So I have to apologize with all my little heart that the following slides are so full of information. It breaks my heart to not have more concrete writing and more pictures, but there really isn't an elegant way to go about these disorders other than just kind of going through them several times over. The thing I want to stress about these disorders is that they're not going to be the most prevalent part of your psych-soc experience, okay? They're not. They are, however, going to show up. The way I like to think about this whole section when it comes to the MCAT is that the questions that come from this section are what I call cupcake points. So if you like cupcake points, it's really good for you to study this section. Okay, what do I mean by cupcake points? I mean that you're in this test and you're tired and you just saw this crazy statistical question that you've never ever thought about. And the next question that comes along is just something that when you boil down the question stem, it's just asking you a definition. It's one of those things that you know it or you don't know it kind of thing. And if you do know it, then they just handed you a cupcake. And then you have like a little bit more energy to finish the test. So this is a really good section for like boosting and especially I think for moving along, because these are pretty fast questions to answer if you know the distinctions. And the last thing I want to say about these is that don't get bogged down by every little detail that we're going to talk about. Instead, write on your slides the distinctions between personalities, because you're not going to be able, unless you have 5 years, you're not going to be able to memorize everything about these disorders. But what you can do come test day is say how that disorder is different from the other one. And that's all you need for these cupcake points. Okay. Let's start. So when we're talking about abnormal behavior, there's a couple of approaches for it. One is the medical model, because we kind of need approaches to think about abnormal, because normal is subjective. And so if it's already subjective, then abnormal is even more subjective. But the medical model proposes to think of abnormal behavior as a disease. This is the model that was prominent in the turn of the century, like in the 1800s, or I guess, yeah, the turn of the other century, I should say. And it was the reason why we began to advance a lot in mental health and the care of mental health. You can think about before the medical model, if people in a community observed abnormal behavior, a typical treatment for that would be like killing the person or like drowning the person. I'm thinking about Salem witch trials, right? Where they observed women behaving in abnormal ways to the norms of their society. And their ways to treat that was to burn them. So you have evidence right there, historical evidence of abnormal behavior, but it wasn't until the medical model, when it was agreed upon somewhere around the turn of the 1800s, that it maybe wasn't satanic possessions, but instead it was diseases. And so once you do that, then you can treat it in terms of a psychological disorder or a disorder of pathology, meaning something's on in the brain, or mental illness. And when you do that, you apply medical concepts to it. So you apply the idea of diagnosis, etiology, and prognosis. I think most people know what diagnosis is, but what is etiology and what is prognosis?
Etiology is causes, prognosis is likely outcome.
The other way, Mo, you said it exactly correct, but the other way around. Prognosis is the one that I think in my mind when like the doctor comes in with the clipboard and says you have 5 months to live. That's how I remember prognosis. Prognosis is just like, what is the likely outcome of it? Etiology is the root cause of what we consider a medical disorder. So you said it perfectly, just backwards. Using the medical model applies these medical concepts. There's a sociology concept that hopefully is ringing a loud bell in your head. What is that concept? It's not a social lecture, but this should definitely be ringing lots of social bells. Don't say McDonaldization, because it's not that one. And I can't even say it. McDonald's, whatever it is. No? Nobody? Yes. Thank you, Nandini. That's right. That's right. Medicalization, question mark, is the correct answer. So that's exactly what's happening. We're using the medical model. There's a medicalization of abnormal behavior. So there's some criticisms to it, obviously. One of the main criticisms is that there's no acknowledgement of the external factors. So in the process of the medical model, we're not talking about, in the case of, for example, women in the Salem lynch trials, in the medical model, there is little concern to the fact that they were experiencing distress because of the external forces in their society that were applying them as women. The other one is that that abnormal behavior can also be seen as deviation from a social norm, and that's not necessarily an illness. We see deviations from norms all the time in our society, but when they get to a certain degree, we think of them as being so deviant that perhaps it becomes an illness. But even then, that definition is kind of iffy because illness in this case can also be seen as how far do we deviate from that norm. You can think about this in the case of communities that have high rates of type 2 diabetes. You can create a sort of idea in a community that there is little deviation from a norm if by a certain age you reach a diagnosable criteria of type 2 diabetes when everybody around you is also doing that. And so then the medicalization of that isn't quite as effective. The other part that is a criticism is that that is probably the one that that I think of most important here is that that medical diagnoses carry social stigmas. So hopefully more social bells are ringing here, because when we think of stigmas, hopefully you're thinking that stigmas can lead to stereotypes, and that stereotypes can lead to discrimination. So a question for you, are social stigmas good or bad? Yeah, thank you, Ditya. What about stereotypes? Are they good or bad? Sophie, in this case, they're also both. They're good and bad. Can you give me an example of a good stereotype? Well, good in quotation marks. Exactly. That's the one that also comes to my mind, Aditya, is that there's a stereotype that Asians excel at math. Or another stereotype would be that men are very hardworking. Um, then the discrimination, is that good or bad? Or both? Bad. Exactly. Yeah. There's no good in discrimination. Yeah, Sophie, I could have asked it clearer. Like, I'm not saying if it's a good or a bad thing subjectively. I mean, like, you can have because you act on the stereotypes, right, and then you act on it. Discrimination, exactly. Sophie brought a really good point that you must have very clear in your head, is that discrimination is an act. If it doesn't leave your brain, it's not discrimination. It's only until it becomes an actual formal act. Okay, so that's a criticism that of the medical model. Something to keep in mind. There's another one that you gotta know, but it's just really easy to remember. It's the biosocial approach. Sometimes it's also called the biopsychosocial approach. And it's pretty much this diagram, which is that there are factors that involve biology, psychology, and society that all come together and that influence the way that we approach abnormal behavior and mental illness. The benefit of having this model is that it's just more broad and more holistic. So instead of saying that the root causes or the etiology of things are everything to do in the brain, you can actually see it as, for example, social stressors. Or they could also be psychological ones. And the difference between social and psychological is that psychological has to do with that sort of thoughts, emotions, cognitive processes, the kinds of things we've been talking about for these last 4 lectures. Exactly, Sophie, exactly, right. A good one is hormones, precisely. Exactly, that's a good one to add to the little biology bubble. Okay, so those are the 2 approaches. But now there's the fact of criteria for diagnosing them. So regardless of whether we're using the medical model or the biopsychosocial model, we got to diagnose it. And the way that we diagnose it is by looking at the symptoms, signs, and the risk factors. Risk factors are, can somebody tell me what risk factors are? Because it's something that unfortunately will pop up on the test. Or an example of a risk factor. Yeah, Sophie, that's a good one. That's a good one. I wasn't thinking of that, but that's also a really good one. That's a tricky one because I think of that as somehow I don't think of that as a risk factor, but it is. One of the things I was thinking about for risk factors is um, growing up in a household where one of the parents has, for example, an alcohol abuse problem. That is a risk factor for a person to develop substance use problems later on. That's for some reason what comes to my mind. But genetic predisposition is absolutely a risk factor. Symptoms are obviously the things that you see, and signs are pretty much the same thing as symptoms. Um, and then but when it comes to diagnosing psychological disorders, you're going to look at whether the disorder meets one of three criteria. The first one is going to be deviance. So that's when people violate norms and expectations that are the society's norms and expectations. And then they go on to be labeled mentally ill. So this is a key criterion for several different types of disorders. One of the ones is transvestic fetishism disorder. Try to spell that. Transvestic fetishism disorder, which is a sexual disorder, or technically it belongs in a class of disorders called paraphilic disorders, in which, particularly for men, dressing in the opposite sex is a source of sexual arousal. So the fact that we call this deviance is because this goes against societal norms and expectations of A, what men do, and B, or I should say how men dress, and B, the source of sexual arousal being just the fact that, dressing in a particular way typically does not create sexual arousal onto oneself. You don't have to remember the term transvestic fetishism, but you can just write there specific sexual disorders. Maladaptive is another way that you can diagnose a mental disorder. And this one, I should say a psychological disorder, because as we'll see, that encompasses a couple of things. So psychological disorder. A maladaptive behavior is one in which the everyday behavior of the person is impaired. So there's adaptive, which means that the way that you behave is going to help you live in society. And there's maladaptive, which the way you live goes against society. So this one is a good one to remember the example for. This is the criterion that's filled when diagnosing substance abuse or use disorder. And the reason why maladaptive is the one that's the criteria for this disorder is because there's nothing deviant about, say, drinking alcohol or about the use of cocaine. You can think about a lot of different things about the use of cocaine, but it isn't something that's considered deviant in society. In fact, it's something considered that wouldn't be totally out of our expectations of, say, a young person in their 20s going to a party at a college frat. So it's not deviant, but it is maladaptive because when it reaches a certain threshold of abuse, it becomes maladaptive, meaning that it impairs the person's ability to function in society. So I hope that made sense. Sophie, the criteria for the first one, you can just write certain sexual disorders, and that's enough for the deviance one. And maladaptive is substance use or drug disorders. Personal distress is the last one the big category for diagnosing a psychological disorder. And this is the one in terms of the person experiencing a great amount of distress. So This one will be really present in the next disorders that we're going to talk about, but it's the criteria that's used for diagnosing depression disorder or anxiety disorder. And so these, in this case, depressive disorders are not deviant, and they are not maladaptive unless they are so severe, in which they then also maladaptive diagnoses can be applied to it. But up to a certain extent, they are not maladaptive, but they do qualify in their milder forms under personal distress. And then the last thing to mention here is that part of why it's so difficult to diagnose psychological disorders is because normal versus abnormal is not a clear-cut line for some of the reasons we've already talked about. And it's actually better to think about it as a continuum so that a person falls along the line at some point in their life. But the difference in terms of becoming a diagnosis is that it goes to the extremes of the continuum. So an example of that is a person can very likely feel blue at any point in their life, and feeling blue is not something that would be typically diagnosed as a disorder. However, if it's taken to an extreme when it is constant feelings of depression as well as loss of interest in things or apathy, then it's considered extreme and it would be then falling into the category of one of these diagnoses. The last part I want to say about the general topics of psychological disorders is how we go about categorizing them. So the main thing you got to keep in mind is the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. Right now, we're on the 5th edition, so you will see it on the MCAT. If you see it, it'll be DSM-5. And that was depressive disorders was the example. You can also write anxiety disorder or bipolar. You'll find that this is the one that we're going to talk about the most. But when it comes to categorizing them, we have now the DSM-5. And this was revamped from the edition 4, which was out for, I think, 20 years. And edition 4 sought to put things into 3 big buckets. And then what they did away with when they revamped to the 5, they actually said, these buckets are, it's clear that these buckets aren't doing the trick. Instead, let's open it up more, and then that way you don't have to fall on one, but rather you can have one or several of the smaller categories apply. And so the DSM is divided into 3 sections, but the one that pertains to the MCAT is section 2, which is just the criteria and the codes. And they've divided psychological disorders into 22 different groups, as you can see them listed here, as I've done nicely for you. Each one of those groups is then subdivided into even more things. And so it just becomes this massive amount of sort of taxonomy that you can kind of think about. I put a link right there in the PDF slides, a hyperlink there for the table of contents. If you're like me, I don't know, I like reading the instructions in a Blender for some reason. And so I kind of like table of contents. So anyways, it's there for your enjoyment. So we're not going to talk about all of these for sure. And you are certainly not responsible for memorizing all of the 22 categories for the MCAT. So I hope you feel some relief. But we will talk about a selection of these. But before we do that, just need to mention the idea of prevalence of psychological disorders. So when we're trying to talk about estimating how many people experience psychological disorders throughout their lifetime, that is a question that falls to the field of epidemiology. So epidemiology is one that looks at the distribution of health in large populations and trying to look at trends on a larger scale. And when they're looking at prevalence, they're trying to specifically find percentages of people that exhibit a certain type of physical or psychological disorder in a period of time. The way that they mostly do the period of time part is in their lifetime. So usually epidemiological data is reported as, like say 36% of Americans will experience generalized anxiety disorder in their lifetime. That's an example of it. That's kind of how prevalence is reported. And it's something to think about in terms of a number that should float in your head is that about 44% of the adult population will struggle with some sort of disorder in their life. So we're going to talk about lots of them. So the prevalence here is that that 44% will experience at least one of the ones we're going to talk about. But the most common ones are the substance use disorders, anxiety, and the mood disorders. Mood disorders, I shouldn't have written mood disorders. Mood disorders is an old term from DSM-4. DSM-5 would call that instead depressive disorders and bipolar disorders. Kind of divided up. Okay, but now we're going to start talking about them. So here's the beginning. This already happened, but this is the formal beginning of lots of information in these slides. And again, please don't think you have to remember everything, but just start thinking of ways in which you can distinguish very essential elements out of everything we're going to talk about. So the anxiety disorders is a good place to start when we're going to talk about them, because they seem to be something that's shared with many other disorders afterwards. But the anxiety disorders themselves are just marked by feelings of excessive apprehension and anxiety. Straightforward, right? We're going to talk about three of them. We're going to talk about GAD, which is generalized anxiety disorder. We're going to talk about phobic disorders and panic disorders. Anxiety disorders are difficult to really get down to the essential diagnosis because sometimes people have multiple subtypes of them. So it's very likely that a person experiencing a type of anxiety disorder has another one also compounded to it. About 19% of the population experience an anxiety disorder at some point in their lifetime. This is, I believe, global, not US. No need for you to remember the fact that it's 19%, but do remember that it's a hefty amount of people that experience anxiety disorders. So what you should think is not the number, but say like, oh yeah, it's a good chance that somebody will experience it versus other disorders we'll see, which are much more rare. Yeah, Sophie. Yeah, exactly. Is GAS general adaptation syndrome? Is that what that is? Oh my God, I'm so good. Yes, but that's exactly right, Sophie. That's a good thing to connect to generalized anxiety disorder. Although we will not talk about that in this particular one. What Sophie's referring to, generalized, wait, what did I just say? Adaptation syndrome. What is G again? I just said it. That is something that you should definitely look at, and it's in the category of stress and coping mechanisms, which is not a part of this lecture, but it's still very essential. So individuals with, thanks, Sophie, with generalized anxiety disorders, like Sophie mentioned, uh, experience chronic. That's the key thing here. So this is what you should be like telling yourself. It's long drawn and chronic, um, and anxiety. And the anxieties can be about events in the past or the future. They can definitely be about minor matters. It doesn't have to be something that's very big. And there's this idea that worrying about things relieves some of the stress because it helps ward off the negative feelings of the thing that creates the disorder, right? So an example there is if you worry too much about rabbits, excuse me, if rabbits create anxiety for you, then worrying about rabbits might help ward off the negative feelings of anxiety because the idea is that emotional and psychological energy is being devoted to the worrying as opposed to the actual object. It can be the case that individuals would worry about how much they worry. So it becomes this very tragic cycle. And as a result, end up dreading decisions and brooding endlessly over them, and especially decisions that have to do around the subject matter of which they get anxious. There's symptoms that you should keep in mind for them, which include muscle tension, diarrhea, dizziness, faintness, sweating, and heart palpitations. All of those kind of make sense. The ones that kind of throw me off is diarrhea and faintness, but the other ones kind of go are in line with what I think about in terms of anxiety episodes. So just bear those in mind, or instead of bearing them in mind, think about how these symptoms might be different from other disorders. Generalized anxiety disorder has a gradual onset, meaning that it doesn't have like one acute event that's like, boom, now this person has generalized anxiety disorder. Instead, it creeps up as it becomes more diagnosable. And it's about 5 to 6% seen in females more than it is in males. The gender thing is important to keep in mind. So make a little note, more females for generalized anxiety disorders. There's another subtype of the anxiety disorders called the phobic disorders. This is the one that I think most people can think about pretty easily, which is marked by irrational fear of something. It could be an event, it could be an object. And the thing here that's important is that the key distinction is that it presents no realistic danger. Okay. So everybody can think about the spider one, right? And the idea that's key about this phobia is that, or phobic disorder, is that that it's irrational because unless the person lives like in a hole in the ground where there's like a spider's nest, there is no realistic danger posed by spiders in your everyday life. Some might disagree. So the phobias tend to be really common phobias, but it's only diagnosed. One can have a phobia, like for example, me, like the whole millipede centipede thing, like just kills me. Like I can't. I just want to cry when I think too much about them. It's not bugs. It's just the God, the ones that like are kind of big and move really fast and you don't know where their ass and their head is. God, it's just, I can't. That's a phobia. Somebody sent me a private message saying holes, like a beehive. And those are phobias, and those happen for everybody. But it's only considered a phobic disorder when it interferes with your everyday behavior. That's the key part, is the interference. So some of the common phobias that you should recognize by name are acrophobia, claustrophobia, brontophobia. JK, don't. I shouldn't have written that. Hydrophobia, yes. And then animal and insect phobia. So recognized by name, the acro, claustro, and hydro, because they might be mentioned without definition of what the phobia is. And then they tend to come with the same physical symptoms of anxiety, particularly the trembling and the palpitations. So I wrote this little story right over here, which is Hilda has 32 years old and unusual fear. She's terrified of snow. She can't go outside in the snow. She can't even stand to see snow or hear about it. Her phobia severely constricts her day-to-day behavior. Key thing there, constricts. Probing in therapy revealed that phobia was caused by a traumatic event. When she was 11, she was playing at a ski lodge, and then she was buried briefly by a small avalanche of snow. She has no recollection of this experience, but it did come up once she was in therapy. So the things to take out from this little story is that the phobic disorder is about snow. So it's really common. And it's another example of how it can be anything. It doesn't have to be an animal or a bug. And the people who have issues with the phobias, their phobias, or excuse me, people with phobic disorders, their phobias go on to be irrational, meaning that in the case of Hilda, she might not even be anywhere near snow and yet still experiences anxiety symptoms. And just thinking about, let's see, and yet unable to calm themselves. Yeah, so basically the same thing. They get triggered by it and they can't calm themselves down. Yeah, Sophie. So that's another example of how they can be virtually anything. Exactly. And they're not trivial. That's one of the things that you should keep in mind if you're going into medicine. When it comes to these things, especially some of them, in our culture, we can sometimes trivialize it because we have it so much in sort of stories and shows and stuff like that. But these are true disorders in which people experience great distress in their lives. So the last one to mention about this is panic disorder. And panic disorder is linked to agoraphobia. Agoraphobia is a phobic disorder, but I'll show you why I didn't talk about agoraphobia in the previous slide. Panic disorder is the recurrent attacks of anxiety that occur because of a sudden and unexpected event. So they have the same physical symptoms as the other anxiety disorders we've talked about. But here's the thing that makes this kind of interesting is that there's a conditioning element, meaning that if a person experiences a lot of panic disorders, the victims might be conditioned, meaning a learning process of becoming apprehensive and thinking about when the next one is going to happen. So then this translates into a concern about going out in public, because the idea is that if you leave your house, then it's going to likely happen that you're going to have another panic disorder and it's going to be exhibited. That creates a condition called agoraphobia. Agoraphobia is a phobic disorder of public spaces. The agoros is the marketplace or whatever in Greek, I don't know. But the interesting thing here is that there is this idea that a person didn't suddenly develop a phobic disorder about public spaces. Instead, panic disorders can lead to conditioning, which then leads to a behavior of avoiding it, and then you become fearful of it. So that's why it's worth mentioning with panic disorders that it's seen as agoraphobia is more seen as an off branch of panic disorders. More women are diagnosed with panic disorders than men are. Don't think about it as 2/3, just think about it as more women. And the onset of panic disorder is late adolescence and early adulthood. Social anxiety. you're gonna have to refresh my memory in the definition. If that's a sociology, it sounds like a sociology term. And I can't I can't remember it perfectly, Sophie, so I can't say if it's well, let me say this. I'd surely social anxiety. Oh, excuse me. I do know what social anxiety is. Is if I'm thinking it's not a sociology term, it's a psychology term, and it's a personality disorder. So there's a social avoidance and anxious disorders. This is not related to social anxiety. That's an example of how it'll begin to get very tricky very soon, distinguishing between these. This is a panic disorder linked to also a phobic disorder. What social anxiety is a personality disorder. We're going to talk about that in a minute. That has a root in a personality trait. Social anxiety has a root in a personality trait. This panic disorder and agoraphobia has a root in anxiety. So everything I've said so far, so I'm glad you mentioned this, Sophie. Everything I've said so far, I haven't said that the person's personality is a risk factor for this. It's everything has to do with anxiety that typically occurs because of some external events. So we're gonna talk now about obsessive compulsive disorders. I say obsessive compulsive and related disorders because that's how it's called in the DSM, but we're only going to talk about obsessive compulsive. It's also called OCD, and there's two principal parts to OCD. The first is obsession, and the second is compulsion. So obsession is what it sounds like. It's just the thought that keeps on coming in your head to the point that it becomes distressing. So you're obsessing over something. The obsessions, though, for obsessive compulsive disorders can be about inflicting harm to yourself or others, about failures, about suicide, sexual acts. These are really common obsessions in OCD. And then another part of this is that there is this conscientiousness that they've lost control of their mind, meaning that the obsession is not something where the people they think it's rational. Instead, these obsessions are where people think it's irrational and they've lost control. So keep that in mind, because later on we'll talk about things where people do think it's rational, in which case we'll talk about being delusional. Compulsion is the drive to carry out, or the act of, the drive of carrying out a specific kind of act. That's a compulsion. So it's like the fact that you feel compelled to do something. And usually in OCD, these have to do with rituals. So common ones are hand washing, repetitive cleaning, endless rechecking, and these are the kinds of ones that come to mind. Don't need to memorize the common ones, but just remember the difference between obsession and compulsion. So obsession is the thought, and compulsion is the drive to carry out an action. So when you marry the two, you have obsessive compulsive disorder. So this is persistent uncontrollable intrusions. So that's the obsessions. And then the urges to do a ritual, which is a compulsion. So this is no joke. They can be pretty severe, and they can definitely impair day-to-day life. This could be to the point where in such examples where people have particular obsessions of little cracks on the street. And so compulsions would be to jump, to not touch any one of the cracks in them. And so then they can, then this means that their day-to-day life is impaired if in fact it's very difficult to physically get from one place to another. Um, the specific types of obsessions, like I've just said in that example, are very specific, are tied to very specific compulsions. So an example is about in terms of being like a germaphobe and then thinking that things are dirty. It's paired up with the compulsion of cleaning. Or here's another one about symmetry being paired with the compulsion of ordering or arranging things. There's an example I came across for this last one, which is like somebody has the obsession of symmetry, so they have to, when they go to a hotel room, they have to take everything off the walls and rearrange the furniture in the hotel room and cover things up that are not fitting the symmetry. Yes, so that would be, Sophie, that would be a good example of the obsession, because as you mentioned, there's the scared part to the obsession. So that's the distress of obsession. And then the compulsion would be to, I maybe not locking it many times, but rechecking the locks many times, perhaps would be the compulsion. And then it's, here's one of the disorders finally that is 2 to 3% of the population. So instead of the number again, just think this is more on the rare side, that you're not dealing with it. And in terms of age of onset, they tend to happen before the age of 30. Yes, Marissa, this would be that could be an example of OCD a certain number of times because of the fact that what you're saying is a ritual. So that's where the compulsion part comes in. The only missing thing to that, Marissa, is that there has to be the obsession part in order to be full on OCD. So now we're going to move on to a different category, which is called from the bucket of trauma and stress related disorders. And from that bucket, we're only going to pick out PTSD. PTSD is one that I have very clear in my mind because obviously I watch Grey's Anatomy, and it's like half of the people in that show have PTSD. It's crazy. Well, at least they portray them as having PTSD. So it's like where the cameras like go like wah wah wah, and like they go short of breath, and there's like the little ringing sound in their ears, and they kind of lose their sense of time and place. God, Grey's Anatomy is such a trash show. I don't know why I keep on watching it, but till I die. So PTSD, just as I've perfectly described with the experience of the Grey's Anatomy characters, is psychological disturbances that are a result of a major traumatic event. The key thing here that I bolded is that it's enduring. So that's the part that you have to keep in mind. When I say enduring, think about this as 2 to 4 months, and this is the disturbances and stress is still occurring because of a traumatic event, then you can call it PTSD. So put down in your notes 2 to 4 months. If it lasts that long, PTSD. So it can be caused by traumatic events, and that is not just the sergeants in Grey's Anatomy who were in war, but it can also be because of rape, an automobile accident, a natural disaster, or witnessing someone's death. These are just some examples that you don't have to remember, but just to keep in mind that you might see it presented in examples that are not war, even though that's what we think about most in our culture. The common symptoms that you should, if you can, bear these in mind are 3, which is intrusion, avoidance, and arousal. Intrusion is the one where you re-experience the traumatic event. So in Grey's Anatomy, people are sleeping and then they wake up and they're like, because they just were dreaming about exactly the same one. So that's an intrusion. The avoidance part is, as it kind of sounds, it's the thing of like removing yourself from society. Um, so emotional numbing, alienation, increased sense of vulnerability. So you kind of just become avoidant. The arousal symptoms uh, are the ones that kind of sound like it. Elevated arousal, anxiety, anger, and guilt. So instead of remembering each one of those, see if you can remember the three categories, which is intrusion, avoidance, and arousal of those. And the prevalence is twice as high among women as it is among men. So this is another place in your notes to say more women, less men for PTSD. So here's a thing that's interesting that would be really worthwhile you remembering, which is for the things that we just talked about. We talked about anxiety disorders, OCD, and PTSD. For those three classes of disorders, there is, when we look at their etiology, we can look at factors of learning and conditioning. So when it comes to anxiety responses, they can be acquired through classical conditioning and maintained through operant conditioning. Yeah, Sophie, I'm glad you finally asked it. I was wondering when anybody was going to ask, why do I keep on saying more women than men? Um, no, it's incredibly on topic, especially when it comes to any social passages. It's going to definitely come up as to why there are gender differences in these disorders. Um, for the time being, there's a lot of reasons why, and biological basis is actually one that's trickiest to talk about. It's actually easiest to talk about social factors, um, which is that for a lot of these illnesses, women are at a higher risk of getting them because of their social roles in society. It's incredibly tragic, but there is lots of evidence that societal factors are the ones that societal factors are a huge influence in women having higher rates or higher prevalence, I should say, of psychological disorders. We'll talk about a little bit about it later on. Just know, in terms of your question for biological basis, is in fact that there is actually not that much out there in biology that that would be a big driver for it. There is some stuff in biology, and we'll talk about it too. So when it comes to these three disorders, something you got to remember is about how they can be based not only in biology and society, but also in learning and conditioning. So remember this thing, anxiety responses. Remember that these three disorders buckets of disorders we talked about, they all have anxiety symptoms. So those symptoms and responses can be acquired through classical conditioning and maintained through operant conditioning. So I think you should really tattoo this on your forehead and look at it every time you brush your teeth and look at the mirror. This is so likely to somehow show up because it does a couple of things. It achieves the asking you a question about disorders, and it also asks you questions about conditioning. So they love to do these double, triple whammies. We haven't talked about this, but hopefully you're familiar with classical and operant conditioning. The first one, classical, is Pavlov. The second is Poor Little Mice. And the idea is that you have a neutral stimulus. So that's the snow for Hilda. And that could be paired with a frightening event. So that would be the avalanche. So in this case, what we're talking about in Pavlov is the neutral stimulus is what for Pavlov? What's the classic neutral stimulus? Hello, ding, ding, ding. Yes, bell question mark. Correct, Marissa. Is the neutral stimulus. And what is that paired with? Yep, a reward, specifically in the form of a prime rib, exactly. And then the bell becomes the what? Yeah, so they learn that. And what does the bell become? The conditioned stimulus. Exactly. Exactly. So the bell goes from unconditioned to conditioned stimulus. In this case, the snow goes from unconditioned to conditioned. And it becomes a fear response. So once you've acquired the fear, meaning you've created a conditioned response, um, then the person would start avoiding that conditioned response. This is now in the realm of operant condition, which is called avoidant learning. And this is where you avoid something with to receive the reward of removing the stimulus. This is one of the ones that's really confusing in operant conditioning. There's two that are confusing. It's like positive reward and positive punishment always seem to make sense to me, but it's the negatives that are funny. The negative reward and the negative punishment. In this case, we're talking about negative reward or negative reinforcement. So the response is to avoid the snow, and the reward is that the aversive stimulus is taken away. Gotcha. So this is an example of reinforcement, not punishment. Yeah, Michaela, that's correct. So for the classical conditioning, the fear response, the fear, or I should say, the snow was first unconditioned, then it became conditioned, which in turn became fear. And then Sophie is right and telling us about negative reinforcement. Yep, exactly. That's correct, Sophie. So that's the Skinner example of negative reinforcement. Perfect. So this is something to remember, that there is great evidence that this is also based in learning something. So when it comes to something you can write down for this, I should have written this down, but cognitive behavioral therapy tries to look at these different learning bases when it comes to carrying out therapy for patients. It's looking at where along in their learning process something went too far, and then trying to rework the learning and the response to things. So it would be a good idea for you to also write, because of this type of etiology, CBT can be an effective form of therapy for anxiety disorders. And as a good segue, the treatments for these types of disorders include medication. So the medication typically targets the anxiety symptoms, and those medications include antidepressants, anti-anxiety medications, and beta blockers. In the case of anti-anxiety medications, it might be a good idea to remember an example of them, which is benzodiazepines. The thing that I would think about memorizing is that a benzodiazepine is not an antidepressant, it's an anti-anxiety medication. SSRIs, as you brought up, Sophie, are antidepressant medications, and we'll talk about them shortly. Let's see, right, exactly. The other thing in terms of treatments for these disorders is psychotherapy and cognitive behavioral therapy. I've explained why CBT in particular works is because of the previous etiology factors we looked at in the previous slide. Now we're going to talk about dissociative disorders. So dissociative disorders are kind of crazy. I encountered them for the first time when studying for the MCAT, and I was like, "What? This is nuts." And this was the area that made me think like, "Oh my gosh, maybe I do like the idea of psychiatry." But these are pretty tricky ones, and we'll talk about in a second why many people maybe think that they really actually don't exist. But for now, we can define them as a class of disorders where the people lose contact with portions of their consciousness, memory, and these losses result in disruptions of their sense of identity. So one of the things, um, uh, yeah, it's crazy. One of the things that I think you should try to remember here is the sense of identity part. This is going to be a key distinguishing factor from the things that we've talked about previously. Because remember, up until this point, we haven't talked about identity. So this is where I think it's easy to kind of start to help yourself distinguish among these many types of disorders we're talking about. So think dissociative disorders, sense of identity, slash also the loss of consciousness or memory. There's three types of syndromes we're going to talk about in this category. And the first is dissociative amnesia. So the amnesia part is the sudden loss of memory, and in this case, of important information that is too expensive due to normal forgetting. What I mean by this is that we've talked about amnesia in the previous lecture when we were talking about retrograde and anterograde amnesia, but here, what we're talking about in amnesia is something that is typical. It's sort of things that are too big to typically forget quite as easily. When we were talking about those in the memory section, we were talking about like, oh, I can't remember the fact of this. What were we talking about? This public health class because the psychology class got in the way. Oh, really? Okay. I think of myself watching soap operas, but then again, it must just be Grey's Anatomy. But maybe you're right. And Fabiana brings up a good point, in which is that more and more we'll see these disorders show up in a lot of pop culture, and it's important for you to not be too swayed by your memories of pop culture, because it might be that those memories aren't exactly correct. Yeah, Fabiana, and a lot of Latin American soaps definitely aren't spot on when it comes to describing disorders. So bear that in mind when you're having mental images of those. So this is important part for amnesia, that you're losing information that's too extensive. I said extensive than you would typically forget. So the memory losses may occur for a single traumatic event. So in the example here, it's a car accident or a fire, or for an extended period of time around the event. So the cases that are typically observed are the ones where people experience this kind of amnesia after disasters, accidents, combat, etc. Examples of this are losing an extensive part of your memory of, let's say, who you were 5 years up until that event. So that gives you an example of what I mean when I say extensive information. The other syndrome you need to know is dissociative fugue, which is when people lose the memory for their entire lives along with their personal identity. So this one is amnesia to the extreme. This is where people forget their names, their family, where they live, where they work, yet somehow still remember certain things that are unrelated to their identity. So this is why people experiencing dissociative fugue still remember how to drive a car or how to carry out math. So examples for this one would be that dissociative fugue could be the lead to people not knowing who they are, yet still being able to functionally wander around and otherwise function in society. The Dissociative identity disorder is the last syndrome that you need to know. And this is the one that is most common in pop culture out of these three. Um, yes, yes, that's the same thing as fugue state. Exactly. Um, it's that is a state that would happen during dissociative fugue. Um, the last one you need to know is dissociative identity disorder. And this one is the one that we see a lot in pop culture. This used to be called multiple personality disorder. And the idea is that there's a coexistence of one or uh, two or more personalities in one individual. These are complete personalities and completely distinct personalities. So there's that movie I never saw with that Irish actor, or is he Scottish, where he's like bald and he's like in a cell and he has like 23 personalities. I don't know. I never saw that movie. It looked really interesting. I don't know if any of you know which movie I'm talking about. It's supposed to be a scary movie or a thriller or of some kind. Because this individual in the movie has I don't know if that's that name of the movie. I forget, Marissa. But this individual, the reason why it's a thriller is because this individual, one of his identities is that of a serial killer. So the other characters in the movie try to make contact with the other personalities that are the mild ones and meek and timid ones, and try to avoid the serial killer personality. These alternate personalities are all really different from the original personality. So that's something to keep in mind. And that the transitions between these two happen very, very suddenly. It's not a gradual transition, but it's a very sudden one. And dissociative identity disorder is seen more in women than in men. Okay, yeah. So Mo, you brought up a good question that I don't sadly have the answer to. Dissociative amnesia is a syndrome that belongs to the category of dissociative disorders. I have to confess, I'm not sure why there's a distinction between a syndrome and a disorder, but I can tell you for certain that dissociative amnesia is a syndrome that falls in the bucket of dissociative disorders. Right. Yeah, I think you're right. Yeah, that's where my thought process is, but I don't want to say it without being fully certain of it. But I think you're right, in which a syndrome is something where you're looking at a number of symptoms, but that somehow isn't robust enough to be called a disorder itself. Right, but it gets confusing. Yeah. Yeah, I think you're right, Mo, in thinking about it in that way. So one way you can think about it for the test, and it seriously won't get more complex for the test. They really won't ever get to the point of distinguishing between a disorder and a syndrome. But say like they mentioned dissociative disorder, you have a selection of symptoms you can pick out of, and when you get syndromes, it's because there's a collection of syndromes that happen that I guess that's what makes it a syndrome under the bigger umbrella of a disorder. The thing that you need to remember about these three basically is that amnesia is the loss of extensive information. The fugue is loss of all of your identity, and the identity disorder, I don't know if they call it DID syndrome. So it might be dissociative disorder syndrome. But in this case, we just call it DID. And that one's the one that is the multiple personalities kind of thing. So I know that that's not very helpful, but just know that what I wrote on the slides is absolutely how it'll be described, because it's just following the DSM-5. So the etiology of these disorders is that for the amnesia and the fugue, they are attributed to excessive stress. So the thing about these disorders is that actually not a ton of information is known about how what their basis is, and there's even sometimes there's even more of a debate whether they're actually real disorders, and they might not be manifestations of different things. But there there's also speculation that there are certain personality traits that might make a person more vulnerable to developing dissociative disorders. Some of those traits are fantasy proneness and a tendency to become intensely absorbed in personal experiences. For amnesia and fugue, for the purpose of the test, think about them as being attributed to excessive stress. So far, we haven't, in the previous disorders we talked about, we haven't talked about stress too much as being one of the sources of the disorders. So this is a good way for you to distinguish dissociative disorders versus other disorders. Specifically for multiple personalities or DID, the causes for that are totally obscure. Like I said, some theorists think that it actually doesn't exist and that patients are intentionally doing role play. And it might be a reason for that might be as an excuse for personal failings. Some that do think that DID is a real condition think that it's rooted in severe emotional trauma, particularly during childhood. But again, little is actually known of the causes of DID, and it still remains one of the most controversial diagnoses that are out there. So we're going to talk about now depressive disorders. And there's a couple that you have to keep in mind for this one. The first one is the major depressive disorder. And one of the things that I like to think about to remember this is that major means, in my mind, persistent. So versus just saying depressive disorder, we're calling it major depressive disorder. When we say persistent, I've indicated here, think about more than 2 weeks of feelings of deep sadness and despair, or the loss of interest. And the thing here is to think about it as persistent and deep feelings, these emotional feelings, negative emotional feelings. One of the central features of major depressive disorders is anhedonia, and that's the diminished ability to experience pleasure. Depressed people tend to lack energy or motivation to tackle certain tasks of living, and then it's often manifested as having a hard time getting out of bed. So one of the things I want to distinguish so far is that we've talked that it could be sadness, but it could also be the loss of interest and the loss of motivation and energy. So you can think about depressive disorders not only being the gloomy things, but it can also be the things that are the drivers for motivation. What I'm trying to say here is that you can have somebody experiencing major depressive disorder who actually doesn't feel sad, and instead just does not have any volition or hedonia, meaning like the motivation to do something or finding pleasure in things. The majority of these cases emerge before 40, but they do happen after 40. Particularly after 40, there's lots of the cases, which is very tragic in my mind, about very older adults who live alone who experience major depressive disorders. They're not in their reports particularly feeling the sad and negative emotions of major depressive disorder, but they are feeling the anhedonia and the avolition part of major depressive disorder. And this has multiple factors, primarily to do with in how society, in Western cultures at least, we, as one ages, typically in society, they get kind of put into different categories and tend to live out lonely ends of their lives. the classification of this disorder is that more than one episode has to occur in their lifetime for it to be called major depressive disorder. But it's a key for you to remember it. It could be two, period, and then it's called major depressive disorder. So it doesn't have to be lots of it. And the prevalence of depression is twice as high in women as it is in men. So yet another place where you can say more women than men. Here's something that Sophie was bringing up earlier that talks a little bit about some of the reasons for this gap. And it's not genetic makeup that we should think about as the reason for this gap, but instead it has to do with role constraints that in typical societies across the board, women experience a multitude of stressors that might be increasing the risk factors for depressive disorders. There is one thing I do want to mention about genetic makeup that is valid for this gap, which is that women's reproductive cycles are such that can lead to greater vulnerability to depressive disorders. Particularly, the thing that you should keep in mind is that women, unlike men, experience what's it called when you stop ovulating? Help me out. Menopause. Thank you. Thank you. Don't blame me. I've been up since 6. So they do experience menopause. Menopause has hormonal effects that can lead to higher vulnerability for depressive disorders. The other thing that you should keep in mind in terms of genetics is postpartum depression is one that is also driven by hormonal effects. And that is depression that occurs typically after a woman gives birth to a kid. And these are hormonal drivers that cause this. And so technically, yes, you can call this genetic makeup because men don't give birth to children and don't experience menopause. However, other than these examples, very little can actually talk about, and very little can actually explain this gap. And where you can really find a lot of explanation is actually in sociological factors. So these are some of the symptoms you need to know for depressive disorders. They're pretty self-explanatory, so I don't think you need to really memorize these, except for some of the ones that maybe stand out that you might not be familiar with. For example, irritable, and perhaps decreased sex drive, decreased appetite. But the thing that you got to remember about these categories is that they talk about the negative emotional symptoms, the motivation and pleasure symptoms, or I should say the loss of motivation and the loss of pleasure symptoms are also ones that are present in this list. Because as far as pop culture would let us know, depressive disorders, we might think of them as mostly to do with the negative emotions, but as I've said a million times, don't be tricked by that. It can also be these other symptoms. So some of the reasons or bases, I should say, for depressive disorders, the biological one is that there's one called the monoamine theory, meaning that there is a decrease in serotonin, noradrenaline, and dopamine. Noradrenaline, remember, is also called norepinephrine. This explains why SSRIs work for helping out with depression. Those are, as somebody mentioned, the reuptake inhibitors, so that serotonin isn't broken down as much and it remains in the neural junction gap a little bit longer. And so just think about it in terms of the causes, in terms of neurotransmitters. You gotta remember low serotonin, low norepi, and low dopamine. So low, 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 three lows. There's also the neuroplasticity theory, which says that disruptive disorders disrupt the neuron's ability to strengthen and adapt, also known as plasticity. Um, and then I just wrote a note here that I don't think you really need to know, but that that there is a lag between the first dose of the SSRI and then the reduction of the symptoms in this neuroplasticity. Forget that last part; that's not important. But this idea is that the depressive disorders actually might mess with the natural plasticity processes that the brain has. There's also the psychological perspective in terms of the causes, and that it says that the vulnerability to this increases through cognitive distortions, meaning that you get into negative thought patterns. So think here about the sort of conditioning and learning stuff about thought patterns. And then that then kind of keep on in the cycle of making you think about these thoughts. And then there's also the attribution of things. So this is where you say when you have a perception of what is the cause of something. So for depressive disorders, it can be the case that one can adopt a pessimistic attributional style, meaning that you self-blame for everything that's happening. And this can go so far as developing something called learned helplessness, which is that you feel powerless and that there's no control in your environment that you find yourself in repeatedly. Learned helplessness should hopefully ring some bells when it comes to operant conditioning with like, I think it's like a little puppy keeps on getting zapped despite everything it does. I can't remember the classical experiment, but anyways, it's an operant conditioning too. The social perspective for the causes of it say that depressive disorders, you might have an increased risk for them if you come from a low socioeconomic status. Also, if there is social isolation and child abuse present. And there's also this interesting one that I recommend you remember, which is that there is this effect of co-rumination or empathy that happens. And this is a classic example seen in which somebody who's caring for somebody who's going through a depressive disorder ends up being themselves depressed and developing similar symptoms for it. This is something called co-rumination or empathy. Sophie, is one of these perspectives why it takes a long time for them to work? I'm not sure which is the it. Oh, right. Yeah, that's the idea, Sophie, about that bullet point about the SSRIs. Right. That's exactly it. Yeah. I don't think you need to remember it. I think that's adding too much information to what you already need to know. Just think about it in terms of the neuroplasticity here is just talking about the disorders affecting the normal plasticity processes. So when it comes to some biological factors, we're going to look at a little bit more closely. We look at them more closely because the MCAT loves to test these, which is for depressive disorders, there's just this notice of decreased activation in the prefrontal cortex. And the reason why that makes sense, and hopefully you don't have to remember it as much as you kind of have to reason it, is because I've talked so much about the lack of motivation to do things. And when you think about the control places of doing actions and the motivations, you should be thinking about the prefrontal cortex, which is that purple spot in the diagram. That's where like all the sort of like, you can think about the command center or the control center is taking place in terms of like higher order activities. So there's decreased activation in there. So then it shouldn't be surprised that it might be one of the causes that drives depressive disorders. The other one is, as I've already said, the decreased production and activity of serotonin, norepi, and dopamine. Please remember this. Depressive disorders, those three go down, low, low, low. Other markers that you can find in depressive disorders are high glucose in the amygdala. In the amygdala, you should be thinking about this is the sort of stress center of the limbic system. So if there's high glucose metabolism, if the passage says that, that means that there's probably something is being activated. And the place that you're activating is the stress place. So it goes in line that depressive disorders might be playing a role in that example. And there's also high level of cortisol, which hopefully you know that cortisol is the stress hormone of our body. Not neurotransmitter, but hormone. The treatments are SSRIs and MAOs. Does somebody know what MAO stands for? A little bit of biochem. Monoamine and oxidase. What do oxidases do? Yeah, oxidase is oxidized. So hopefully what most of you are thinking for oxidases is that oxidases just break shit, break things. And how do they break them? Through an redox reaction or an oxidative reaction, to be specific. So what are they breaking? They're breaking monoamines, okay? So if it's an inhibitor, what are you trying to do? Exactly, right? So you're trying to inhibit the breaking of a monoamine. And what's an example of a monoamine? Dopamine. Yep. Dopamine, norepinephrine, and epinephrine are monoamines. And you know they're monoamines because they come from one amino acid. Which amino acid do they come from? Come on, there's only 20. Well, there's more, but you need to know 20. Somebody should be Googling this. What is the amino acid that produces or that is the structural basis of? No, I don't think so. You're tricking me, but I don't think it's that one. Is it phenylalanine? It's not tyrosine? Oh shit. I thought it was tyrosine. Stop it. You're all confusing me. Is it really that? No, it's tyrosine. It goes tyrosine, then L-dopa, then dopamine. Okay, somebody definitely, this is important for all of us to have straight. Tyrosine. Oh, from phenylalanine. Okay, gotcha. Okay, so thank you, Sophie. Whew. Alrighty. Yes, that makes sense. It makes sense that at some point tyrosine was made from phenylalanine. But what you need to know is that for the MCAT, you really need to know that tyrosine is the structural basis for the monoamines, dopamine, epinephrine, and norepinephrine. Okay? So don't forget that. Not serotonin. Okay. We're going to move on to bipolar disorders. And it's a good thing to talk about bipolar disorders after depressive disorders because we'll see that they show up. Sophie, so you all have to Google and make a flashcard and write it down that tyrosine turns into dopamine and dopamine turns into norepi and norepi turns into epi. You all need to Google it, put it on an Anki, and don't forget it. You don't have to know the structures per se, except for tyrosine. And Monica, I think you're right. I don't want to say for sure, but I think you're right. I forget, but that's a secondary thing to remember. But the thing you must remember is the tyrosine part for the monoamines. So it makes sense to talk about bipolar after major depressive disorder because it shows up in bipolar disorders. So bipolar disorders are, the way I think of them is just adding another layer to the depressive disorder because you have to alternate between a cycle of depression and mania. So there's two types of disorders in the bipolar category. One is the bipolar 1, and the other one is bipolar 2. One is characterized by having one manic disorder. This is a little tricky because it also can or doesn't necessarily have to have a major depressive disorder added to it. But the key thing here is that bipolar 1 has one manic episode, and bipolar 2 has one hypomanic episode and one major depressive episode. Just really remember the bolded part that 1 is manic and 2 is hypomanic. And those are what they sound like. Manic is the one in which a mania state goes above the baseline of the mood, of the baseline mood. So if you look at this diagram on the right, there is the mood, which is the baseline, and then the mania range is the one that goes at the very top of the cliff. Likewise, the depressive one is the one at the very bottom of that curve. These disorders are seen equally in males and females. So of everything I've just said, this is the first one you have to think, male and female equal. And the onset of this is typically late teens for it. There's another one that you need to know, which is called cyclothymic disorder. And this one is the one that oscillates not quite in the deepest depression and not quite in the mania. Instead, it goes between something in between hypomania and another range that's called dysthymia. Dysthymia is the one that's not quite depression. And so cyclothymic disorder is characterized by the oscillating between those two. Onset ages, sadly, I have to say, yeah, you should not memorize, but definitely recognize that. Let me give you an example, Sophie. If they say that the onset stage of this bipolar disorder was seen in a 3-year-old female baby, and then they say true or false, false, super false. That's the kind of way in which you're going to see it. They're definitely not going to trick you too much to say like it was seen onset is 13 versus 20 years old. But those are the kind of big sort of age categories that I recommend you keep in mind. So one of the ways that I like to think about this is by looking at this diagram. So look at how they've labeled the colored wavies and see how you can compare it to the average person. The average person tends to live above the baseline. And then obviously there's like a little natural curve below the baseline, but nothing in the average curve looks like the oscillation as you find in bipolar 1, bipolar 2, and cyclothymia. Manic is, so manic is the ones of emotion, like it can be seen as like, think about the positives taken to the extreme. And the way they're taken to the extreme is like by like feelings of grandeur, feelings like when let's say like a positive feeling is like being driven and motivated, that takes it to the extreme by being obsessed about something. Right, and then a good example of a manic episode would be something of like spending all your money, going wild in Vegas, that kind of idea. But the difference for psychotic is something we'll talk about a little bit onwards that has to do more with that would show up more in schizophrenia and other personality disorders. So one of the things I recommend is take a peek at that particular slide, that diagram, excuse me. This over here is the symptoms for bipolar disorders. And what I've done is you can see that these are exactly the same symptoms for the depressive disorder, but now it's added the manic symptoms that show up during the manic episode. So here is your categories that are emotional, cognitive, and motor symptoms, but now added those two things. And so here is like much better examples of mania than the ones I was just trying to say. And not surprisingly, they look like the opposite of the depressive disorders, right? So elated, euphoria, racing thoughts, hyperactive, increased sex drive, fluctuating appetite. It's not surprising actually to hear of cases in the bipolar disorder syndromes where particular individuals who have bipolar 1, because remember that's manic, it's all the way to the top, in which those are periods in which those people feel like they actually are in great productivity and geniuses. And in fact, if it happens to be the circumstances that they're all driven towards appropriate avenues, they could result in really incredible work during the manic episodes. But the distinguishing part is that for bipolar, there's also depressive episodes. So you should think about this in terms of the oscillation of the two things. And please do not think bipolar is DID. That's also a nice way that they can trick you, which is thinking that bipolar is about bipolar personalities. And it's not. That's dissociative identity disorders. The causes for bipolar disorders from a biological perspective is seen as the increase in norepi and serotonin, particularly during the mania phase of the bipolar disorder. So remember, I said depressive is low, low, low. Here you have high, high, but not for all three. Instead, it's just for norepi and serotonin. Remember that. Please remember that. There's also the fact that it's highly heritable. So there is genetic components here that we won't go into the explanations for, but we do have evidence that there's actually high heritability for this one. So this is a good thing for you to circle because so far we haven't mentioned that something has a high heritability until now. Treatments that are medical treatments, I should say pharmaceutical treatments, try to target the swings and control the swings. So there's not one that tries to address all of it, but instead the therapies try to lower the curves, whether they're in the upper or the lower realms. And so those include mood stabilizers, atypical antipsychotics, antidepressants, and psychotherapy. So you can see among those, there's the ones that try to lower the tops and raise the bottoms. Now we're going to talk about schizophrenia, which is yet another class of disorders that I think pop culture has given us lots of images of, but many of them might be right and many of them might be wrong. So it's important to go through the definitions so that you can parse out where your thought process is correct and isn't. So this category of disorder is marked by delusions, hallucinations, disorganized speech, and maladaptive behavior. The delusions is an important part of schizophrenia, which is the false belief that false beliefs that are maintained that are out of touch with reality. So the clear examples that you see for this is going to be the reference, the persecution, and the grandeur. And then there's hallucinations. So those are going to be the perceptions where like sensory perception, when in fact there's no stimuli that goes in there. So think about this in terms of the first time that we spoke about the fact that light hits the retina and then that gives perception. The hallucination means that there is a perception of something being there, that there is absolutely no physical stimulus to produce that perception. So think about it in that granular kind of neurological way. There's two ways in which these symptoms show up for schizophrenia, and one is the positive and one is the negative symptoms. The positive symptoms are about adding something that's the abnormal, and the negative is about taking away something that is normal. So Um, we'll talk a little bit more about those two symptoms in a second, but you just need to remember the bolded things that schizophrenia comes with the deal of positive and negative symptoms. And this is not to equate in the subjective way that positive is good and negative is bad. Instead, positive is adding and negative is taking away. And there's gender differences. Men begin showing these in late teens, whereas women tend to show this later than men do. So this is just the thing that you need to remember is that men earlier, women later. So here's the subtypes of these two types of symptoms. The negative symptoms are behavioral deficits. So the typical ones are flattened emotions, apathy, and the poverty of speech, meaning that the speech is broken and missing essential elements. Physical deficits include catatonia, which you can think of rigidity or immobility. And these are harder symptoms to treat. So that's kind of an important part to think about, because as you can kind of imagine, these are difficult things to kind of fill the gaps for those things. Positive symptoms, on the other hand, are easier to treat with medication. And these include things that are like the hallucinations, the delusions, bizarre behaviors, and the wild flights of idea. As we've seen previously with bipolar disorders, there are the ways in which we can lower these kinds of things. But the negative symptoms of schizophrenia do not resemble the symptoms of the depressive swings of bipolar disorder. Instead, these have to do more with affect. And so those are harder to treat. So one of the biological etiologies for this can be seen in terms of some brain structures. The one is the thalamus, and which is thought to be a little bit smaller with people experiencing schizophrenia. Hopefully you remember that the thalamus is the center for relaying information from one place of the brain to another one so that information is processed. And the smaller cortex, and the cortex being the exterior part of the brain. So the lobes that are at the outermost surface, as well as decreased frontal lobe activity. That's also shown. And then enlarged ventricles. So this is something that you may have not heard of, or maybe you have, but ventricles are the spaces in the brains where there's only cerebrospinal fluid. And so in patients with schizophrenia, CT and MRI scans show that these ventricles are enlarged more than they should be. There's also, in terms of the neurochemical activity, higher dopamine effects. It's about 6 times higher than the normal amount of dopamine that should be seen in the brain at any point in time. Don't remember the 6, but just remember that it's way, way higher. And so a good treatment for this is to have dopamine antagonists. And so dopamine can help reduce the positives. Antagonists can help reduce the positive symptoms. Yet another instance here is where we have high heritability. So now we have 2 cases of heritability. So for this one, think high dopamine. So because it's so important, it's one more time. Schizophrenia, high dopamine. And so the treatment is antipsychotics and dopamine antagonists. Major depressive disorder, low, high glucose in the amygdala. And yes, and I got a direct message. The other heritable one was bipolar. And then high levels of cortisol in the brain. And then bipolar disorder, high norepinephrine and serotonin. And dopamine elevated during mania. Now we're going to move on to personality disorders. And I'm going to breeze through these because even though there's so many of these disorders, they're actually not the likeliest thing that you'll see on the test. However, it is important for you to look at them and distinguish between them, because if they do show up, they can be really easy cupcake points for them. Personality disorders are fascinating. They're marked by extreme and inflexible personality traits. So everything we've said so far, we haven't said traits. Now this is the first time we're saying traits. So when you see a question and they're talking about a personality trait, think personality disorder. And these traits cause distress or impaired social and occupational functioning. So you got a trait that's too extreme and causes some issues, either with distress or day-to-day function. Individuals with personality traits, those traits tend to be exhibited in really excessive and rigid ways, and they have a really hard time adjusting the degree to which those traits overtake other ones. And then the personality disorders usually happen in late childhood and adolescence. So this is the first time we mentioned something that shows up a little bit earlier in the childhood side. And something important to think about is that these disorders are egosyntonic, meaning that people think they're correct and necessary. So another contrast is depressive disorders are ego-dystonic, meaning that the individuals are observing the fact that this is not correct behavior and that is not helpful for their goals. Egosyntonic means that these people think like this, their behavior is correct and necessary. Okay, so really remember this about personality disorders, that this is a big one for which people think, the people experience it think, oh, this is right for me to experience this. These personalities, there are quite a few, and they're clustered into 3 categories. Or one way that's even easier to remember the categories is the 3 W's: the worried, the weird, and the wild. The worried is the anxious, fearful, the weird is the odd and eccentric, the wild is dramatic and emotional. I urge you to think about them as the 3 W's, because instead of remembering all of these different adjectives, you just remember 3 W's and think, is that adjective fit a worried, a weird, or a wild? And then you know. Oh, but I should mention though, the MCAT would not test you saying like, which of the 3 W's is this? That's not an official term at all. They would ask you if it's anxious or fearful, blah, blah, blah. But it's, in terms of your recognition of those clusters, the W's are much easier. So I'm afraid we should probably go through quite a few of these. I'm going to skip over the last column, which is the male to female ratios. And I don't think you should focus too much on these ratios yourself, but it is helpful to have nevertheless. But let's talk about the first one, the worried. Avoidant personality disorder is as it sounds, just like the excessively sensitive to the social interactions, particularly when it comes to do with rejection, humiliation, shame. Social withdrawal and social anxiety is one of the main parts of this disorder, and pretty self-explanatory. The dependent personality disorder is a little similar, but this one is talking about self-reliance and self-esteem. They passively go along with decisions and subordinate their own needs. So here's the one that I kind of love because it's so damn confusing. There's the obsessive compulsive personality disorder. Now tell me why they didn't do a better job of distinguishing it, but this is not OCD, okay? This is not OCD, this is OCPD, obsessive compulsive personality disorder. If you're not frustrated, then I don't know what's wrong with you. I find this very frustrating. This is where you can definitely slip up and get it wrong just because of the distinction of one word. This is a personality disorder and not an OCD. This one is preoccupied with organizations, rules, schedules, blah, 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 and extremely the people experiencing it is experience is extremely conventional, serious, and formal, and unable to express warm emotions. So this is not OCD. Remember how we talked about OCD having to have an obsession, uh, usually one that has to do with more deviant things like sexual things, harming other people, those kinds of things, or yeah, we talked about or bizarre things, and then the compulsion, the ritual to do something. An obsessive compulsive personality disorder, we're not talking about obsessions and compulsions. Instead, we're talking about an extreme personality, that's rigid in terms of the organization and also unable to express emotions. So please don't make the mistake, because it's a very tempting mistake to make that they're the same, but they're not related. One is to do with um, anxiety-like symptoms, and this one has to do with the personality. And remember, this one is egosyntonic. They think they're doing the correct behavior. Moving on to no, Mo. They don't have that many, because think about it this way: OCPD, they think they're doing the right things. So, and this is the case for all of these disorders. They're egosyntonic. Whereas OCD has elements that are ego dystonic, where they're conscientious of the fact that it's totally limiting their day-to-day living. And the OCD ones have anxiety symptoms. So one of the things to think about what Mo is saying here is that we don't talk too much about symptoms, because their symptom is just an excessive trait. That is the symptom of these personality disorders. So I hope that makes sense, Mo. The odd and eccentric. So we go to the weird. Schizoid personality disorder, schizotypal personality disorder. These are the ones in which they are schizophrenia-like, but they are not schizophrenia. Instead, it's a personality disorder. So for the first one, it's difficulty forming social relationships, an absence of warmth. So you can think of here of the negative symptoms of schizophrenia. Schizotypal is the ones of the oddity of thinking, perception. These might resemble more of the positive symptoms of schizophrenia. And then there's the paranoid personality disorder. And this is the one in which showing pervasive and unwarranted suspicion of others. One thing I should have mentioned in back here, is that for hallucinations, folks, and delusions, if you want a movie, you should be thinking of A Beautiful Mind of John Nash, the mathematician who, this is true life. He had schizophrenia, and he had the hallucination that he was being persecuted by, I think it was like Soviet spies or something like that, and that he had to be reporting code breaking and stuff like that. That's the one I wanted to mention to you, if you want an image. Okay, let's move back. The dramatic and impulsive, the wild. So these tend to be pretty self-explanatory. Histrionic is the overly dramatic. The narcissistic, slightly different, is being self-important. So the first one is overly dramatic and the exaggeration of things. The narcissistic is about grandeur to the extreme. Borderline personality disorder is an unstable self-image, mood, and interpersonal relationships. This one can also be trying to confuse you with bipolar and dissociative identity disorder. This is not neither of those. This is a personality disorder, and it has to do with acting in the highs and lows, which is why sometimes it sounds like bipolar disorder, but it's not. It's a personality one that has to do with the highs and low of this particular personality trait. And there's the last one, which is the antisocial personality disorder. This doesn't fall under the anxious and fearful cluster. It's under the dramatic and impulsive. Um, yeah, exactly, Fabiana. Exactly. Borderline examples will show up where they have wild mood swings within a single day. They're impulsive and unpredictable, but they are not bipolar. It's not a bipolar disorder. Antisocial personality disorder is not under the first one, which is avoidant personality disorder, even though it's has to do with yourself versus social groups. This one is actually much more on the impulsive and dangerous side. It's about violating the rights of others and not accepting social norms, and explosive and reckless. So when you think antisocial, and what you're thinking is like little timid and hiding away from people, in terms of psychology, you actually have that wrong. What you might be thinking about is actually avoidant personality disorder. When you think about antisocial personality disorder, you should be thinking somebody who clashes against society, actively clashes. So please make a note of that, because I think pop culture would let us think that antisocial is the sort of the timid thing. And if you're going to think that, you should be thinking the first one, not the last one. Hopefully that makes sense. Okay, we're going to transition into more of the physical stuff. So we're slowly leaving the sort of psychology, and we're transitioning towards some of the nervous system stuff. And we're going to talk about somatoform disorders. So somatoform disorders are those that have physical symptoms, specifically that can't be attributed to a physical cause or substance abuse or mental illness. So it's kind of weird, but we're talking about disorders that something actually can be seen, but you cannot figure the cause for it. And there's some subtypes that you have to remember for these. So the first one is somatization disorder. And these are long-term symptoms that affect multiple parts of the body. The other one that's kind of similar is conversion disorders, except that conversion disorders focus specifically on neurological symptoms, especially like sensory organs, kind of like the things responsible for perception. So in the example, it's blindness and numbness, experiencing these sort of perceptual symptoms, but without knowing the cause to those disorders. There's illness anxiety, that's also known as hypochondriasis, which is what we use what we think about when we call somebody a hypochondriac. And that's a very legitimate disorder that in the extreme is actually a very tragic and life-limiting one, in which the individual is literally anxious of becoming ill. And yeah, I got a private message. Yeah. And there's also body dysmorphic disorder, which when you think of like body dysmorphia or dysmorphic images of your own body, and that's the preoccupation with the body image. And then there's pain disorder. And this is the one in which chronic pain is occurring in one or more areas of the body. So these are all subtypes of somatoform. So remember that all of these can be observed. They're all physical in some way, but they cannot be traced to a cause. So up until this point, folks, everything we've said, we've talked about different causes for them. None of this. You can think about the somatoforms as the bucket of like, who knows why this is happening, but it is happening. There's a contrast to this, which is kind of confusing for the MCAT, and they love to do this because it makes people get less than ideal scores, which is that there's somatoform disorders, but then there's factitious disorders. So there's the somatoforms, which we talked about the fact that there's actually something. And so in this diagram, it's the top line in which the symptoms are taking place. Forget the motivation part for the somatoform. There's nothing to gain in the person experiencing these symptoms. And so the diagnosis is a somatoform disorder. The difference happens, however, when there's symptoms that are intentionally occurring. There's no motivation for them, and there's some sort of internal gain for it. And this is called a factitious disorder. So here's the thing, folks, that makes it different, is that there is something to gain in having these symptoms. And that's what makes a disorder factitious versus somatoform or somatic. Factitious, the thing to gain here is not the lottery ticket. The thing to gain is something called sick roll. Can anybody define sick roll? No, no, not quite, Sophie. I'll talk about why not. Yeah, Michaela, you're right. That's an example of sick roll, or that, excuse me, that's a manifestation of sick roll, being that because you are sick, society says that you are excused from your regular responsibilities, say going to school if you're a kid, or going to work if you're an adult. That is a sick roll. So when you adopt a sick roll, there are certain things that you are then allowed and not allowed that you would normally not be allowed if you weren't sick. That's a good question. Illness experience. Illness experience. It's reading about. God, I need help with illness experience because I can't remember what that one is, but I know that the thing that distinguishes it from sick roll is that sick roll, Marissa, is one in which that's a societally labeled one. So sick roll is not something that you come up with as an individual. Society defines what sick roll is. And once you adopt that label, then certain things change. So all of these things, Sophie, no causes. There's no explained cause for factitious nor for somatic or somatoform. There's no causes to the symptoms in any of these. The only difference between factitious and somatoform is that in factitious, there's something to gain, and the thing to gain is sick roll. So you can think about this as the lady who experiences legitimate intense stomach pain and keeps on going back to the hospital and keeps on being tended on by nurses and doctors and keeps on getting treatments and keeps on getting hospitalized, ambulances. And the thing that's being gained is a sick roll for that lady. There's the difference is that the lady does want to be in the sick roll, meaning treated by doctors and nurses and all these things. Exactly. But they are actually sick. Correct. They are sick and they want to use sickness to their advantage, which is sick roll. Somatoform, that's not the case. They don't want to be sick, or not that they don't want to, but there's nothing to gain. They don't have a sick roll in mind. The one you don't need to know too much is the third one, which is called malingering, which is when still the cause is unknown, but the motivation is an external one. And that one is basically money. It's basically time off. Um, so think about it in terms of like a kid. Nah, I don't know if a kid, but it's just this the fact that you have um, legitimate symptoms that are that you do not know the cause for it. We cannot figure out the cause, but the person does have an external gain. And an example of that is by receiving money, like paid time off or sick time off, or receiving free time, like time off. And that's called malingering. In all of these three, the symptoms are real and the causes are unknown. Malingering is the one that I think you don't need to remember, but you definitely do need to remember factitious because it's going to be put in with somatic and you got to know which one is which. The last two things we're going to talk about before we're done are now in the nervous system disorders category. So we're no longer talking about psychological disorders. We're talking about nervous system ones. The first one is Alzheimer's disease. And this is one of two diseases you need to know for the MCAT. In fact, you don't really need to know a lot of diseases for the MCAT, but Alzheimer's is definitely one of them. And the main marking distinction of Alzheimer's is dementia and the loss of cognitive functioning. So it's not only the loss of memory, but also the loss of cognitive functioning, which leads to disorientation and problems with thinking. There's biological markers that you must know about them, which is the deficient blood flow to the parietal lobe, maybe or maybe not that one, but the one you need to know for sure is beta amyloid plaques. These are plaques that develop around neurons that are located in a region of the brain called the substantia nigra. They also have enlarged ventricles, which we saw in schizophrenia. There's a genetic component to Alzheimer's disease, and this one has to do with a gene for a protein that's a precursor to beta amyloid. So it's something that can be traced in a genetic risk factor kind of way. And this is more common for adults that are over the age of 65. I think I have, no, I don't have a, oh shoot. I thought I had a slide with the name of this, but that is the name of the region in the brain. Oh my God, no. I said the wrong thing. Ha ha. I'm so sorry. Please forgive me. Please, all of you forgive me. Substantia nigra has nothing to do with Alzheimer's disease. Nothing. What you need to know about Alzheimer's is that beta amyloid plaques, like the diagram shows, accumulate around the axons of neurons, particularly in areas of the temporal and parietal lobes. More important than the regions of the brain is just the amyloid plaque that's there. And that's the one, as you can see from it. I mean, you can just, by looking at that diagram, you can kind of see how neurologic impairment might be affected. Neurologic functioning might be impaired. What's one of the ways in which, just by looking at this diagram, especially the one on the right, what is one of the steps in the transmission of neurologic impulses that's might be interrupted by the beta amyloid plaque? Action potentials. Exactly. The ones that I'm thinking is like saltatory action potentials as it hops in between each one of the gaps. Parkinson's disease is the other disease you need to know for the MCAT. This has to do with the substantia nigra. This particular disorder is not marked by the cognitive and memory deficits of Alzheimer's. Instead, this one has to do with the central nervous system impairments that affect movement that are driven by dopaminergic neurons. There's symptoms that you have to recognize, and the mnemonic for those is TRAP, which is tremor at rest, rigidity of the muscles, akinesia, and posture. Akinesia can also be called bradykinesia. And that's defined as the loss of the voluntary movement. The causes for this is decreased dopamine production in the substantia nigra. And this diagram tells you this where the substantia nigra is. It's densely populated with axon terminals and gap junctions, hence the gray color of that part of the brain. And in those regions, it's just found that the dopamine production is much, much lower. So you can see in the diagram, the lower one is much lighter in the case of Parkinson's. And this is an area of the brain that is responsible for initiating and terminating movement. And the treatment for Parkinson's disease is L-DOPA, which is a precursor of dopamine. So if what you have is a decreased production of dopamine, the idea is, well, let's give the person dopamine to help them with that. This unfortunately isn't a cure of Parkinson's disease, but it is something that helps with the symptoms of it. As of yet, Alzheimer's disease and Parkinson's disease there is no cure for it, and there is lots of intense research devoted into figuring out ways to cure people of this disease. They're both pretty tragic diseases in their own right, and it's something that most people in some form of their life have experienced themselves or know somebody who has experienced them. So these are two nervous system disorders you need to know for the MCAT. And folks, that is the end of this lecture. And if you have any questions, I'm more than happy to take them. And I also have questions myself that we can go through right now, if you want to go through them. There's also, I'm working on a, what do I call it? I was gonna say pamphlet. I'm working on I don't know, like this 3-page thing with statistic stuff for you to have. My hope is to have it for you on Wednesday, and so that you can reference a lot of these things for the statistics you might need to know for Psych Soc, as well as for other sections of the MCAT, with the exception of CARS. And so hopefully I can get that to you on Wednesday, and then you can use it as a sort of reference tool to talk about it. There was really no, right, Sophie. So yeah, that's exactly what I'm talking about. Experimental design stuff is something that I think is worthwhile just putting in a document that really most of you have probably already, might have already touched on the fact of what's the difference between the average, the mode, and the median, those kinds of things. Because if we had done a lecture on it, then we would have, it's far too short, and I thought it better to go through all of these that you're going to do today. And these are much more difficult, the things we just talked about. So, what will suffice for the experimental design stuff is just really like a 3-pager. So questions, shall we? Yes, I've got 2 yeses. Alrighty, so let's go on for some questions. Oh shit, okay. We did this, we did that, now we did this. Okay, questions. Do you mean unmute yourself, Mo? And like sing? Like
Yeah, I had a question. Can I just say
it? Yeah.
Or ask it, yeah. So I guess schizophrenia is its own, it's not a personality disorder. It's its own psychotic disorder. That's its own umbrella disorder, right?
Yeah.
That's different from schizoids and schizotypal, which are personality disorders.
Yep.
What's the difference? Is one of them I think the key things in schizophrenia is delusion and hallucination, right?
Yeah, exactly. So you're entirely right. They're not the same thing. Schizophrenia, we talked about delusions and hallucinations that are key features in that disorder. In the um, in the personality disorder for the schizoid and the schizotypal or typal, um, remember that all of those are driven by a personality trait, one or very few personality traits that go to the extreme. Another key characteristic of those personality disorders is that they are ego syntonic, meaning that the people experiencing schizoid and schizotypal think that they're doing the right thing. And also the symptoms for those have nothing to do with hallucinations or delusions, which are key parts of schizophrenia. Does that make sense?
It does, yeah. So follow-up question on that. So what type of behaviors would a person exhibiting that we would diagnose with schizotype or schizo?
Right.
Is it just abnormal social behaviors? So it really is relative?
Right. No, yeah. So it's not entirely relative. So when we talked about the personality disorders, since we're not looking at the delusions or the hallucinations aspect of it, we're looking at the erratic behavior part that is typical of schizophrenia, but doesn't classify entirely as schizophrenia. So the erratic behavior, the better than me struggling to think about them. So we talked about the aspects from schizophrenia that have to do with forming the social relationships, and in the case of schizoid, the way that I like to think about it is to think about those things are the negative symptoms of schizophrenia. So meaning the things that are lost, and those are in the schizoid. In the schizotypal are the positive symptoms of schizophrenia. However, when I'm saying this is that we're not adding the ones that have to do with the major ones, which are hallucinations and delusions for those two things. So as you're trying, the MCAT will likely not ask you the distinction between schizoid and schizotypal, but it will ask you probably the difference between the personality disorder and the schizophrenic disorder as a whole. And so the distinguishing parts there is that with the personality disorders, you're looking at specific traits that tend to orient themselves towards the positive or the negative sides of schizophrenia. Does that make more sense?
Yeah. So I'm trying to recall what the positive and negative I guess factors are. Is it positive or negative symptoms? So so the personality disorders, they exhibit the negative symptoms, but the positive symptoms, which is hallucinations and delusions, that's in the psychotic disorder, the schizophrenic disorder.
Right. Did I pass it? Sorry, I'm trying to find schizophrenia. Okay. So when we're talking about positive and negative, the positive is definitely the hallucinations and the delusions. But including in the positive, there's also the bizarre behavior, the wild flights of idea. Those would be more closely related to the traits in the personality disorder seen in the schizotypal. For the negative symptoms, we talked about the flattened emotion, social withdrawal, and apathy. Those might be more closely seen to the personality of the schizoid personality disorder. What makes this the schizophrenia is that both of these symptoms occur in one person to varying degrees, plus the fact that it's marked with, when it comes to the positive symptoms, for sure, the hallucinations and the delusions. So I'm glad you're asking this question, Mo, because it's really kind of difficult to parse out. But when it comes to the personality, think of the fact that people in the personality disorders are thinking that whatever traits they're that whatever the emotions they're feeling because of the traits is in their minds absolutely necessary for their daily functioning. When you're thinking of schizophrenia, one of the main hallmarks of it is these excesses in the form of hallucinations and delusions. And they're not even worried about whether it's egosyntonic or dystonic because they're totally disconnected from reality.
Right. That was my next question. So I guess you can only these diagnoses are mutually exclusive. Like, so you can only you can't diagnose someone with schizophrenia and schizotypal or schizo
Uh-huh.
personality disorders because they
Right.
either have the positive symptoms or they don't.
Right. Right. Yeah, you're right. Mm-hmm.
Okay,
Mm-hmm.
and because it's an irrelevant question whether it's ego syntonic or ego dystonic if they're not even grounded in reality.
Exactly.
Got it.
Exactly. So when
And
I mentioned dystonic, I mentioned things like anxiety disorders and depression and OCD. Those are dystonic because those are cases in which the individuals can tell that it is not serving their day-to-day living.
right.
And and it doesn't even matter whether it's dystonic or syntonic because this is like John Nash thinking that they're persecuting him in real life.
Right.
So,
So the difference between my follow-up question as well. So I think this is the last one. So the difference between obsessive compulsive disorder and the obsessive compulsive personality disorder
mm,
is one of them. The former recognizes that this is disruptive to my life. This is a behavior I want to diminish
mhm,
or mitigate. The personality disorder is ego dystonic. If I said that right.
absolutely.
Yeah. So they
No, ego syntonic.
okay they it align, their behavior aligns with their ego, their, what they perceive as correct, so that's why that's considered a personality disorder. Got it.
Perfect.
Okay, I got it. Thank you. That's pretty much all my questions. Thank you.
That's perfect. So hopefully you all wrote down absolutely everything Mo said because that was entirely right, especially when it comes to his clarity with the distinction between OCD and OCPD, which is just unfortunate how similar they sound, and they're totally different. Just because of not just, but one big distinction is that sense of is it in line with my thought or is it against my line of thought, dystonic or syntonic? Thanks for those great questions, Mo. Because they really hit at the home of these really nitty gritty details that will definitely be things that will try to trip you on. Okay, have a go at this one. Okay, so if you could, yes, Sophie, I'll gladly send the questions that we do. Okay, so please send lots of responses in the private message. Um, lots and lots. So far, I only have a few. There's a hell of people here. Okay, come on. It's a short question. All righty, here they come. Great. All righty. Lexi, would you mind unmuting and telling us why you picked letter C?
Hey, Diego.
Hey,
So I chose C because from what I remember, A, B, and I wasn't sure about D, but it could also fall in the category of those being positive symptoms of seen in schizophrenia.
yeah, yeah. What made you not go with D?
Because I feel like delusions may fall under hallucinations.
Good, good. Yeah, what you did there is really important, which is that there was this is arguably one of the easier kind of questions you would get, probably a little even too easy to get this question. But it has this good example of like of two that are easy to cut out, and one is an iffy one, but another one you know for sure is out of the question. The correct answer for this one is C, and it's exactly because of what Lexi said, that it's just a question of figuring out which of these four examples is taking away something that should be their normal behavior, whereas three of these other ones should theoretically be adding to it, or one should just be a made up response. So uh, um, A, B, and D are all examples of positive syndromes, positive symptoms of schizophrenia. Um, and uh, and then, oh, affect is how do you define affect? Affect is oh gosh, it's sort of the external behavior. Is that how to best define it? So I can think of it in terms of a better, yeah, manifestation of emotion, right, towards others. The key part of affect is the manifestation of it. So it's like a person who has a pleasant affect is a person who has a happy disposition and sunny and cheery. Lots of people are mentioning B as one of their potential ones that they were thinking about, which is disorganized behavior. Why might disorganized behavior not be a negative symptom? Can anybody take a stab at that? Yeah, some messages are coming through that it's that disorganized behavior is actually adding something rather than taking away something. Uh, it's right. Yeah. So it might be tricky to think about disorganized as like, let's say you're taking away from, let's say, an organization baseline, but don't think about it that way. Instead, ask yourself the questions here of like, what is getting added and what is getting taken away from schizophrenia? And in particular, we talked about flattened affect or flattening of emotions when it came to the negative symptoms. So that's what C should probably ring a bell for you as a negative one, because you're disturbing affect. I can see why it's tricky to think like, oh, maybe you're disturbing organization, but we don't really talk about organization as a sort of essential part of behavior. So instead, you think about it something that's being added. Right. So I got a message thinking of saying that if somebody was a highly organized person, in that case, if there was more follow up to this question saying that there was perhaps a personality trait that made a person more naturally organized, and then schizophrenia brought about disorganized behavior, that could raise the question of whether it was a negative or positive symptom. But without more context, then all we have to think about is in terms of like, what do we remember about positive and negative symptoms? And that's the case here. So don't be too tempted to apply a situation to something when there isn't. Alrighty, next question. Alrighty, I started getting, give me some answers. Give me answers with a question mark followed. This is a good one for a letter plus a question mark. I actually have more confident Lots of answers without question marks. That's great. Okay, but I need more answers. I've got too few. Alrighty, more answers, folks, so we can move on. Jonathan, give me an answer. Alap, give me an answer. Henry, Mo, Naomi, give me an answer. Okay, I need one more before we move on. All righty. Thank you, Jonathan. That's what I was. There we go. Okay. Now we have more critical mass. Thank you. All right. Okay. Jonathan, why do you think A? Or what do you think A? A? Can you explain your Okay. Okay. Alrighty. What do you think about when you see the term feature detection? What comes to your head? Is it blank space? A void? Yes, good. Okay, good. Good, good, good. Alrighty. So what makes you think about this as potentially A is the fact that you're picking out. Aha. Uh-huh. Okay. Alrighty. Good. No, that's not bad because that's exactly what feature detection. Uh-huh. Yeah, good. Manri, why did you say B question mark? Okay, so Manrit says because he hears his wife laugh. Yeah, so small details. Right. And you're not right. And it's uh bottom up processing. You're working your way up. Okay, so hearing laughter or hearing sound and then calling it, thinking about it as laughter, and then thinking about the kind of sound is the sound of his wife. And investigate. Oh, that's a good, yeah. That's a good, it's good that you noted the word investigate because that would be very much bottom up processing to confirm. Manri, you're exactly on the right track for thinking about bottom up processing. Alrighty, let's see. Good. Those are really good reasoning so far. Marissa, can you tell us why you said A, but then you were like JKD and more on the JKD part?
Wait, okay, I'm just gonna use my camera or not camera, my mic. Sorry if you can hear my dad in the background. But I chose A at first. I think someone said it where it's like you're picking out a specific thing, like a characteristic was what I was going for. Canceled out B because bottom up was like you don't know, you're like you don't know what's happening, so you're using like different clues to like put something together. Vestibular sense has to do with like what do you call it? Like head positioning and acceleration and stuff. So that wasn't that. Then signal detection is like where you see something or like you hear something, but then like you hit or it's like you hit it or you miss it. That idea. So then him hearing his wife's laughter is like that
Yeah.
idea with like the square box and then it's broken up into 4 squares. So then that's what I thought of. Sorry, that wasn't a very good explanation, but yeah, that's why I chose D.
No, that was an excellent explanation. And that was kind of exactly where I was at with this question. I think this is a tough question because when I read this question stem, like Sophie just asked me, I think about cocktail party effect, and I'm like, where the hell is cocktail party in my options? I don't know if anybody of you was just like looking for cocktail party when you read that, because this is exactly what cocktail party examples were like when we were talking about it. And so instead, I'm hit with these 4 things that I never think about in terms of cocktail party. The one I would take out is vestibular sense. The reason I would take that out is because vestibular sense by itself doesn't mean anything. It's not, it's a sense that we have, but it's not telling me any sort of process. So that one, I hope most of you, it looked like you were able to kind of take that out of the equation. Then it gets tricky with the other ones because the other ones seem legitimate. It turns out that the right answer for this question is D, signal detection theory, for exactly the reasons that Marissa said. Oddly enough, Manreet brought this up when he was explaining why he thought the answer was bottom-up processing, because he focused on the word investigate. But investigate actually should make you think more about signal detection, because what that says is that the man made a choice. And so he's going to investigate whether his choice was right or wrong. And that is signal detection right there. If the person makes a choice and there's no mention of the investigate, I think this question becomes really tricky to talk about, because any one of those options might be possible, except that the detection part is the one that makes this, the investigating, the making a choice and investigating is the part that makes this a signal detection scenario. And it's got the perfect makings for signal detection. You take away, you have noise, who literally hears the noise of the music. And then you have to make a process of whether something is present or isn't present. What, in this case, whether it's the voice of his wife or it isn't. And then you check, and then you find out if it's going to be a hit or a false alarm in this case. If you appreciated this to be a tricky question, you were right. This is a tricky question. And this is a really good sort of estimate of like how hard a question could be regarding this kind of subject. Next question. Oh, wait. Lab says, yeah, go with gut feeling. Yeah, gut feeling is usually good. And yeah, there's another message here that bottom-up processing seems ever so tempting because you do that. The reason why I wouldn't think too much, now that I know the answer, maybe if before I knew the answer, I would have justified bottom-up processing a lot more. But bottom-up processing really requires the person, the description to be something like, there was sound. The sound was high or low. It was male or female. It was wife or no wife. So you really gotta like piece together the different details to arrive from sensory information to then what is the perception of something. Here, I think the question is trying to get you to focus more on the fact that you've made a choice of what it is, and now you're going to confirm it. If anything, now that I think about it, this might be more like top-down processing, actually, because the person is saying, that's my wife. And you turn around and you're like, okay, that is my wife. Now that I think about this, this question could be very hard if B was actually top-down processing. That might actually be difficult to answer. Next question. This one might have been a little bit easier for people because there's the answers came flowing in. Um, Jonathan, can you tell us why you say it's B? Okay, right. So major means, big, right? Like we spoke about. Uh-huh. And you're right. When we talked about major, right? We talked about it. Alrighty. I think that's a good argument. Sophie, why do you say C?
I said C because major depressive disorder is characterized by lasting more than 2 weeks. So you can kill A. And then it doesn't have to involve thoughts of suicide or suicide attempt. The word must is really like an extreme word there. So that can be killed as well. And then same thing with D. Not everyone that has major depressive disorder has feelings of sadness. And again, that word must is an extreme word, so it can be killed as well. And then C is your correct answer because it's a good word with the word may. It's not always the case, but yeah, it may involve a decrease in sleep.
You're exactly right, Sophie. And when it comes to the option D, what could be other symptoms that people who have major depressive disorder feel?
I don't know if you're asking me, but
Yeah,
it
yeah.
could be like irritability, not necessarily sadness.
Right, right. Yeah, exactly. It's the not necessarily sadness part. Exactly that. Yeah. So you've got it spot on, Sophie. Um, so yeah, Jonathan, the thing about B, the only thing that makes B wrong is the must. Is the must. It could absolutely be B if the word said may. If instead of must you put may there, you couldn't answer this question because B and C are both true about major depressive disorders. This is a classic extreme question for the MCAT. You will not find a question on the MCAT that says like, which of the following is true regarding like, I think that's too close of a definition type question for them to ask, but you will definitely find the pattern where they're gonna throw out the extreme. And when you see the extreme, you should be extremely skeptical of that answer because of the so few things in all of the MCAT subject matter is an extreme. Everything is a may or likely. Very few things is a must. And if it is a must, you must know it because then you know that that extreme is right. But for the most part, it's going to be a may. That's going to be the right answer. So that's the only reason B is wrong. Next question. Oh, there's some things. And as Sophie was telling us excellently, it doesn't have to be sadness. So that's the important part also that I want to reiterate. All right. Alrighty, folks, more answers. I love it. So far, they're all over the map. This is great. Perfect, perfect. Lots of forgetting. I love it. Okay. Good job, folks. All right, Fabiana, can you tell me what why you chose B and what the ego means to you? Fabiana, are you with us? Yeah. Okay. So yeah, the belief that ego is the part that we show to society that follows norms and conventions. Yeah, I think that's almost there. The I you're right in the follows norms and conventions part. The there's another part though that does the job of the sort of outwardly expression, the sort of thing that we show to society. So you're almost on point with that one. Uh, there's lots of other answers here. I'm curious about though nobody picked D. Why did nobody pick D? Yeah, exactly, Sophie. It's a perfect irrelevant question there. It's along the lines of Freud, um, but it has nothing to do with this in this case. What does libido have to do with? Yeah, I guess you just said that. Yeah, is the survival part, right? The motivation for survival and growth, right? Right, exactly. Um, which is nothing to do here. A lot of you were answering C, which is the case. This is that is what is the right answer, is C. The superego is the part that, if you remember, we were talking about, that is the mediating part between the ego and the id. And the superego is, in trying to mediate the two parts, is the one that can experience the anxiety, because it's the one that has um, two different clashing parts of their personality. Um, because of the fact that the id is driving the motivation for the extramarital affair, but the ego is the one saying that that is amoral. So it's the super ego that is the one that excuse me, I'm saying this wrong. It's the ego, it's the super ego that is the moral one. um Oh yeah, Marissa, sorry. I'm saying this the wrong way. I'm looking at this iceberg, and instead of helping me, it's stripping me up. Um, well, we have it's the superego. That's the correct answer, because it's the one that deals with the moral imperatives. And so it's the one that is responsible for creating the sense of anxiety about it. And as Sophie says, ego is the one in the center of the two halves, the shoulder with the angel and the shoulder with the devil. And exactly, so the superego is the moral one, the angel, and the ego is the balancing one. Correct. Yes. I'm so sorry. I was looking at the iceberg and it tripped me up for a second. So the superego is the one that has to do with experiencing the anxiety, and the anxiety comes through out of the ego, not out of the superego. However, the one that is responsible for the anxiety is a superego. Yes, exactly, Sophie. You can think about it in that shoulder. The only thing about when I mentioned the whole angel and demon thing or devil thing on the shoulders that is not quite applicable for this is that, remember that the id is entirely in the unconscious. So there's no in that analogy, there's no devil talking in your ear, because it's something beyond your conscious perception. However, the superego, the angel thing, is in both realms of the unconscious and the conscious. And so that one has the potential to kind of talk in your ear and say, and produce the anxiety. So just bear that in mind when you have that analogy in your head, is that in reality, the devil one isn't on your shoulder because of the unconscious part. So you really don't ever think about the id talking in your brain. That's just a driver that is totally beyond your perception. All right. So I think we have time for one more question. Let's do one that's really juicy. Okay. Ah. Oh, scheiße. I'm sorry, folks. Hold on. This is all wrong. I wanna give you this question. Okay. Sorry about that. It's technical difficulty. Okay. You may have seen the answer. Maybe you didn't. We'll see. It's a good question regardless. Alrighty. Here you go. Okay, folks, I need more answers. Answers with question marks are perfectly accepted. Uh-huh. Uh-huh. Okay. Alrighty. Maybe one more. So we have critical mass. That's not an answer. There's no B. Cool. Alrighty. I love this. Oh my God, I love this. You're all wrong. Oh, this is wonderful. Every one of you is wrong. This is wonderful. Okay. Michaela, as I've just said, you're wrong. Can you tell me why you picked D?
I picked D because there's definitely, well, I can't say definitely because obviously I was wrong, but I thought that there was a biological perspective because they mentioned the gene. And then I went ahead and made the connection to behavioral because I was like, oh, the gene represents the likelihood of becoming an extreme athlete, which is a behavior. But obviously, that is not a correct thought process. So,
Where do you think your process failed? The
um,
entire thing or only part of it?
I would say making the connection between biological and behavioral on
Okay.
my own when the question stem didn't necessarily guided me there.
Okay. Yeah, that's a good evaluation of the error. Perfect. Good. Um, let's see. Da, 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 da. Let's see. Lots of D's. And Nandini, can you tell us why you picked B? Pretty please. Are you with us? Perfect. So gene influencing is behavior. Yeah, yep. And the thought was that it's biological. Perfect. So you're entirely right, Nandini. You're so right that the moment you see DRD2, you should be thinking biological perspective, because how else would you look at the perspectives of looking at genes? What else would it be other than biology, right? We don't know of any other perspective that cares about genes that isn't biology. But you're not entirely right. There's yet another one of those. Before we talk about Sophie, you're hilarious, Sophie. So before we talk about more of the options, I want to know though, do any of you have a method for these Roman numeral questions? Yeah, so true or false, eliminate some, kill answers. How about this? Is there do any of you have a method where these Roman, like you're coming in the test and you like see one of these ugly ones that has the Roman numeral? Do any of you go to the answer choices first before the question stem? Oh my goodness. Okay, we have to take some time to talk about this. Alrighty. Y'all should think about incorporating this. When you see a scary question like this with Roman numerals, before you even read it, just go to the answer choices. For example, in this one, notice that Roman numeral 3 shows up a lot. If, using logic, if Roman numeral 3 is wrong, you only have one option. Does that make sense? If Roman numeral 3 is a wrong one, then you only have one right answer. The likelihood, the statistic likelihood that Roman numeral 3 is going to be wrong is not very high. That should tell you that Roman numeral 3 is probably going to be one of the right choices. The other thing that you have to note about Roman numeral questions is that you look at them and you're like, only one has a single Roman numeral in it. And the chances that only one of a single Roman numeral is wrong is very high. Because normally they want to mix and match. So there's a great likelihood that A, Roman numeral only, or 1 only, is not the right answer. The thing you also want to do when you're doing these questions. So after I've done this evaluation of thinking like one only is probably not the right answer, and three is probably involved in the right answer, the next thing I have to do is look into and see what is the one Roman numeral that's shared twice in these answer choices. And that's a 1. And that tells me I have to focus my attention on Roman numeral 1 because it shows up twice. So in this sort of quick evaluation, 3 is likely right. 1 by itself is likely wrong, and 1 shows up twice. So I have to look at the answer choices carefully to see that what is 1 plus 3. And the other thing, the last thing this tells me is that Roman numeral 2 shows up only once. So this tells me that like this might not be the right answer, because just as A is Roman numeral 1 only, Roman numeral 2 only once kind of falls in that same category. It turns out that the right answer is C. And I'm not saying you could have arrived to that question by doing what I said in logic, because it could totally be that the right answer was A or D. But what you have to know about these Roman numerals is that the way they are presented has a statistic likelihood of telling you where they're headed in the right answer. If you haven't seen this concept before, it's time you start looking at them, because you're going to discover some of these things I just said when you're doing your practice test. You're going to discover that standalones are hardly ever the right answer, and that the ones that are repeated the most are likely among the right answer, and the one that has 2 are the ones that you have to focus your attention on. Okay, did y'all get that? Do you understand what I just said? Okay. So, yeah, okay, thanks for asking, Michaela, because I wanted this to be clear. When I'm saying that the Roman numeral 1 shows up twice, I'm not saying that it's correct. I'm saying that it should tell you that Roman numeral 1 is important, and it might lead you to the right answer because it shows up twice. When a Roman numeral shows up only once, it might not be the right answer because you take away the ambiguity. It is or it isn't. And when a Roman numeral shows up 3 times, it tells you it likely is included in the right answers. So when I look at this, even before I look at the question, I'm thinking 1 and 3 are already statistically important answers. Gotcha? All right. The answer is C. Yeah, Michaela, this is like, yeah, so Nandini, now I'm going to stop talking about this logic thing, and now I'm going to talk about why it's the right answer. No doubt, everybody had the right idea about Roman numeral 3. Biology, genes, don't even think about it. Just click it, move on, be happy. Shit gets tricky with 1 and 2. When you think of behavioral perspectives, I think it was with Michaela, I think we were talking about behaviors. That was what came to mind with behavioral perspective. Don't think about that. Think about Skinner. Think about operant conditioning. We talked about behaviorists being only interested in observable behavior that happens as a function of learning that behavior. They were so crazy about the fact that personality had nothing to do with the fact of any internal drives. It had everything to do with you learning things. Behaviorists were just crazy. Bandura should come to mind when you think about social cognitive perspective. And he came from the school of behaviorists, but he said, yo, you guys are too strict about the fact that we learn everything in personality and that everything that we are is a result of learning from an environment. There's or like our learning experience. And he said that one of the things you think about Bandura is the Bobo doll, is that there's a process of social learning, and there's a process about where the environment teaches you something. So when it comes to DRD2, we actually spoke about this. We spoke about social cognitive in last lecture, but here in this lecture, we spoke about DRD2 when we said that people with the dopamine 2 receptor mutation might be more thrill seekers. But we said that that doesn't mean that there will be thrill seekers. It just means that they will, if their environment provides them the ability to do that. So in the example I gave when we were talking at the very beginning of this lecture on the biological perspectives of personality, I was saying that you might have this gene, but you need the environment also. So like if you're a thrill seeker, you need also to have mountains so you can go skiing down black diamonds. So it's not just the gene alone. So the thing that cares about environment is social cognitive perspective. Behaviorists don't care about environment. They don't care about internal motivations. They only care about the learning, the conditioning, meaning like you try something out and you're rewarded with a punishment, or you get a punishment or a reward. And from that, you either cement that in your personality or you avoid it. That's all the behaviorists cared about. Bandura talked about there being an environment. That's why social cognitive comes into play. So it's a tricky question, I admit, because it has one aspect that's really easy, but when you look at 3, it's presented in 3 options. So that doesn't really narrow it down. We did say how when you're looking at these option types questions, these Roman numeral questions, the fact that B is 3 only might not be the right one. But that still leaves you with C and D, and that's a tough one. But it would be less tough if you remember that social cognitive is allowing for personality to be shaped through society, aka the environment, and circumstances, whereas behaviorists are just strict. It has to come from very basic learning processes. Alrighty, folks, I've gone over by so much now, and I am so sorry about that. But I hope you enjoyed these questions. I will send out a PDF of these questions to you, likely tomorrow or tonight, so you can have them for your reference. I'll also continue to work on this statistics stuff for you and experimental design. It should be pretty brief. It's just telling you how to just keep in mind different things of like trends and stuff like that. We can discuss those more in office hours. So be sure to stop by if you can. If you can't, message me and we can find some time. I hope your study's going great. I hope you know all your amino acids. Don't forget, tyrosine is L-dopa. And have a great rest of your Sunday. All right. Unless there's any other questions. Yeah, exactly, Sophie. All righty, folks. Have a great rest of the day. Don't study right now. Take a break. Go outside. See the sunlight for the love of God. All right. Okay.